Right, I think we are all just about ready. Thank you so much, Mark, for all the tech support. And there we go, precisely 10 o'clock. How good is that already? Good timing. Welcome everyone to this CCAM board meeting. My name, for anyone new, is Usman Khan. I'm the chair of the trust. So I'm going to start. We have a preamble, a little bit of preamble before we get going. But I want to be able to, I'm going to start by welcoming staff. I'm going to start by welcoming Karen as well as our incoming non-exec. Most welcome. You've already joined a couple of subcommittees and been involved with other things, but you're more than welcome joining us. And just to confirm, as we always do, that this is not a public meeting, but a meeting held in public. So it's lovely to see those who join the meeting in person, but also those joining online to be able to observe the meeting. There is also the opportunity at the end of the meeting, if colleagues do want to be able to ask any questions. Before we then get going, I do want to just take the opportunity to be able to make short comment on the public disturbances that we have seen nationally over the last days and weeks. I think everyone was very thankful that yesterday didn't end up in further violence. But just to say that as a trust, we have made a public statement, and I would like to thank colleagues from the trade unions and also colleagues from our staff networks for their involvement in being able to get a single, very strong statement out that as an organisation we deplore these illegal activities in any of their form, and we certainly, obviously, as a frontline service, would say that we would not allow or accept any of those behaviours with respect to any of our staff or in the way that we are able to deliver our services. And it may be, and hopefully, we won't see more of that, but what we will say is that if we do, that statement sets out exactly how we would expect to be treated, all our staff to be treated, and also what we would do if we don't see that, if we feel that anyone engaging in criminal activities, illegal activities, how we will respond as a trust. So I did want to be able to say that before we move on. In terms of apologies, as we can see, we don't have Simon. For those observant, but David is providing most excellent cover while Simon is having a well-earned break, and his deputy Matt, in full uniform, very good Matt, is also in attendance, and then with Sarah Wainwright on leave, welcome Andrea joining us and covering today. Also, in terms of those away, we have Janine Compton away, and also Subu, our non-executive, again, well-earned holiday. Howard, welcome Howard, you're joining us online. We have other colleagues joining online. So then want to be able to move on, just declarations of interest again. It's a standing item, but it is a very important item. There are written declarations of interest that we all have to make, and quite rightfully that we do that. But I think just have a pause to be able to say if there's anyone who feels that there's any particular matter that they need to raise in terms of a declaration of interest in relation to the agenda today. And I just do that pause to be able to see if there is, but if not, we can then move on. And we first of all look at the minutes of the last meeting, and we need to be able to go again the two issues of being able to say are they accurate, and then we'll come up in terms of the action log which Peter will run us through. But if I can just pause and say Is there anything in relation to the minutes that any colleague wants to be able to raise? Not seeing anything. That's fantastic. If I can then ask for approval of those minutes. Thank you very much, Paul. That's your first nod of the head, which is very helpful to have. And then to move on to the action log, I'm going to ask Peter just to take us through that.
Thank you, Chair. Won't take long. There are just 2 actions on the log related to gaps in assurance from previous meetings. Both reports on both are due to come to the meeting in December. One relating to the Medicines Distribution Centre and the other relating to IT.
Excellent. Thank you so much. Then it comes to my report as chair, and that's outlined in the papers, and I'm just going to pick up on a couple of the points. I think just overall, I just want to say that for those, especially those who join fresh, to be able to see that there's a lot that's new at the moment. There's a lot as a trust. The executive have been doing an incredibly large amount of work in pretty pressing circumstances in terms of being able to sort of do multiple plate spinning. And we're going to see much of that, the value of much of that coming through the board today as we talk through and officially launch both our strategy and our values. And I think those are, I would sort of pause to be able to see that it's lovely that both come together, because I think strategy without values and values without strategy really don't hold as well as they do together. So to be able to bring those together. Also to say how we will report, colleagues will be able to see is a real test for eyesight. We were just talking about eyesight, to be able to go through all those graphs and to be able to test whether you have got the right prescription or not. But what it's being able to say is that what we want to be able to do is to have the richness of data to be able to provide the assurance, the public assurance that we need to be able to provide that we are working to our values, we are working towards the delivery of a strategy, and that these papers are here to be able to support that assurance process. I will say that we're likely to evolve that process over time. I'm mindful that we always, when we look at the length of a board meeting, you think, wow, we must be able to get through all those items pretty timely fashion. But actually, there's a lot there. And I think we will have to see over time how the iterations to make sure that we're getting this as smooth as possible. So I would imagine that this will be a little bit of a test run, and that as we move to our October meeting, there'll be further nuancing. So for colleagues to be able to bear with us. I'll just also make mention for colleagues that we have board seminars. Basically, we have these board meetings, and then in the other off months, if you like, we have board seminars, and really do as a trust try and make the most of those. Our last one, we were looking at sexual safety. We were looking at our new strategy, and also we looked at digital, because digital is going to be an increasingly important part for the NHS going forward, and certainly for ambulance services. And it was really valuable to be able to have that time in those board development sessions to be able to link to what we get then in terms of the assurance we get in our formal board meetings. Also to just say that, to highlight that we will have 2 colleagues, very happy to be introducing 2 new colleagues for October, Chief Paramedic Officer Jacqueline Limbridge, and also Jen Allen, who will be joining as Executive Director of Operations to replace Emma, who will be, this will be Emma's last board meeting, but you'll be in our seminar meeting next month. And I'll say a few more words, so you're not going to get away with it entirely, just to be able to say Emma at the end of the meeting. Also, to make the connection with the Council of Governors. As a chair, I've chaired various organisations, but not worked with Council of Governors before, and I've really, really valued already my interaction with the Council of Governors meeting, and also individual governors in terms of how they are providing that additional layer of governance support, and it really feels like support. It really feels that we have that critical voice that's out there within our communities, and our communities, not just community, our communities, providing that voice, providing that critical friend perspective. And I really do see the value of it, and to be able to, we now have a new lead governor in Andrew Latham, and Andrew, who I met when I first came in and really connected with him, and very much looking forward to seeing how we work going forward. The last thing I think to say is just, it's interesting with the role, there's a lot that's externally focused, and it's a real joy to be able to go out to Sussex, Surrey, Kent, and also Frimley, to be able to connect with colleagues there. And I have to say how welcoming those colleagues have been, and how those colleagues are really understanding, not that ambulance service is a sort of something to worry about around winter pressures and all the challenges around handovers, but to be able to see that we are actually a system enabler. And I'm really hearing that back from colleagues, as I am with the Southern Ambulance collaborative that we are now part of. So it's a really nice part when we connect it with our strategy, and we will hear more about that. So I will leave it there and be able to now move on to our Chief Executive report. And I'm going to hand over. Oh, sorry.
I think it's just got the Audit Committee report.
Oh, sorry, Audit Committee report, and then we're going to move on to that. So Audit Committee report, and I think I'm going to go over to Michael.
Yeah, thank you. Thank you, Chair. Just a few words from me. The Audit Committee last met on the 18th of July, and at the committee we were pleased to approve the annual report and accounts of the Trust. Just a minute to reflect on this. So our annual report and accounts, an important document in giving assurance to taxpayers and users of our services, and also more widely to NHS England, that we are using our financial resources appropriately and in accordance with managing public money and all the other requirements. So the Trust received an unqualified audit opinion. We met the statutory timetable. For those who may be interested, our accounts are consolidated into the accounts of NHS England and ultimately presented to the House of Commons, from which all our money flows. So we have complied with that statutory timetable. We had opportunity to reflect, however, on how the production of the annual accounts and annual report took place this year, and exceptionally grateful for the transparency and openness of our Director of Finance, because I think what we recognise is that while people worked incredibly hard to get these delivered, there are key lessons to be learned going forward, particularly about improving our financial capability. And really that's not a reflection on the quality of our staff, it's really ensuring that we have resilience in our finance team. And our Finance Director will be looking at that over the next month, and we'll come back to the Audit Committee and the Finance and Investment Committee in the autumn. We now have new internal auditors, BDO. We had a presentation from them on where they are with their work. And it was also an opportunity to reflect on the previous internal audit reports and the assessment they awarded to the Trust for the preceding financial year 23-24. They raised issues around the control environment and made a number of recommendations about how that could be improved. Again, I'm pleased to say that the Trust had already identified that controls within the organisation probably needed strengthening, particularly in light of the significant challenge that we face in, like all of the NHS, in making better use of our financial resources and delivering our financial plan for this year. So again, in September, we will return to the issue of control and to discuss with the Executive their plans for responding to various recommendations, and also the actions that they themselves have initiated. We Briefly touched on cybersecurity. Like all organisations, cyber risk is increasing at significant pace. There is a new way in which organisations' resilience in the public sector will be assessed, and this is moving from an existing evaluative tool to a much more rigorous tool which the trust will use going forward, and we will look at the implications of the output of that in December. Also draw the board's attention to the fact that we do have a new digital strategy that has been developed, and that has within it a clear objective to strengthen the trust's cyber security. We also looked at risk management. The audit committee focuses on two things. Have we in place a robust process for ensuring that all risks are captured and mitigated, and generally following the principle that there should be a clear line of sight from the front line for those delivering our services to the board. Again, I would pay tribute to the work that Margaret and her colleagues have done to strengthen risk. I think we recognise there is still more to do, particularly around the culture change of getting people to understand what risk is about. But I'd also stress that it's not just about risk mitigation, it's ensuring that our colleagues, our people within CCAM, know that risk is being managed in an effective way, and where there are opportunities to develop innovative services that benefit all those that we serve, our patients, we need to take those opportunities. Good risk management is about creating that framework that people feel confident that they can generate new ideas and implement them, as well as never losing sight of the importance of maintaining patient safety. So the second thing that the Audit Committee looks at is the extent to which the key risks, the strategic risks that the Trust has identified that need to be mitigated, that these are comprehensive and substantive and reflect our assessment of risks that the Trust are facing going forward, both in the short, medium and long term. I'm pleased to confirm that we thought that the identification of risks was comprehensive and we had nothing to add at this point in time, but as ever we will return to risk at our September meeting. We looked at a number of initiatives, reports and strategies that the Trust has put in place, particularly around procurement and digital. Once implemented, I think these will have a significant impact on improving our control environment, but the various committees of the board will continue to monitor these. And then the final point I would make is we are aware that in the past there have been issues about our emergency preparedness, response and resilience. Again, a lot of work has been done to respond to a number of external reports that have raised issues. We want to ensure that we have got appropriate governance in place to monitor the implementation of these, the response. And we have established a subcommittee of the Audit Committee that will meet this afternoon to look at the forward plans and report accordingly to the board. Chair, that's all I wish to say at this point in time. Thank you.
Thanks so much, Michael. And just to, again, a word of thanks in terms of the work that you do and the work that the committee does, especially when you see we have so many different competing needs. And at the time, especially, is that changeover of auditors, I think it's also really important to be on the ball, and also I'll say it later, but Simon, thank you for the work that you're doing to be able to not just respond to what we need to do over the current financial year, but looking at system improvements that are needed again. So thank you for that. Right, I now will move over to David, who's going to take us through the Chief Exec's report.
Thank you, Chair, and I'm clearly not Simon, so delivering this report in Simon's behalf and on behalf of the rest of the exec team. I mean, the paper is there in this red. Happy to take questions. I just wanted to highlight a couple of points. It was about a year ago when we started the journey of developing our new clinically led strategy, and here we are today to formally launch it. We've had a good run of the strategy. We saw it in April. We've translated it into a set of objectives for the year. And today we have a new BAF that reflects those priorities and what we may have to focus in year one to start doing that journey. But I just want to start with a thank you to all of our people, all of our partners, all of our patients and communities who have contributed to help us get to this point. Quite genuinely, it's made a huge amount of difference when we have been out speaking with the region, speaking with ACE, speaking with our partners around how are we going to work together in the future to change the way in which we meet the needs of our patients. And that's where it all started. The needs of our patients are changing, and therefore we had an imperative need to change. The second thing that I wanted to reflect on is I went alongside with Michael actually to a meeting with Southeast regional leaders where it is becoming more and more apparent that the NHS will have to review its operating model over the next 10 years. That's an active piece of work that government is working on. And what was very heartening to see is that everything that we have heard from our people, our patients, our partners that has shaped our strategy puts us in a really good position for how we may fit that future model. So it's really encouraging, I think, to just reflect and remind ourselves that the journey that the board is now starting, which will be a journey, it will be a multi-year journey, will sit in the context of not just doing this by ourselves, but doing it in the context of collaboration, partnership, and working as part of a broader health and care system. As part of the work that we have been doing, we visited, Margaret and myself, with Ian Smith, the chair of Surrey Heartlands ICB, our lead commissioner, and Karen McDowell, our hub in Ashford, which is a really fantastic model that we may be looking at expanding. It is indeed one of our priorities for this year around how can we start to shift the way in which we deliver clinical needs. I'm very pleased to say that some of the work that has happened in Kent will see some award and national recognition through some HSJ awards, as well as some of the work that we have been doing in Portal, in UCR, through our colleagues in EOC, which you can see in the report. So that's a really fantastic example of two nominations, not full recognition yet, but it is a form of recognition when somebody comes and says, some of the work you're doing there is really good, and that work just so happens to really be underpinned and at the core of where our clinical strategy may be. So it's really good and very pleased for those teams. I know it means a lot to them to seek that recognition, and thank you to everybody who's contributed in getting that nomination over the line. The last thing I wanted to reflect on, which is not in the report, is some of the good partnership work that we've done over the last month at our Partnership Forum meeting with our trade unions. We have approved the uplift of the ECSWs from Band 3 to Band 4, which is really fantastic news for about 500 of our colleagues who will see their pay uplifted from September. So again, a fantastic piece of news that we have trailed at the board, but we're happy to say that has been approved and that we will be seeing out on pay packets over the next 4 weeks. That is probably everything at this point in time, but happy to take questions on anything that I've said or anything in the report.
Thanks, David. I will open that. I should also have said that in relation to Michael's paper, because we have Michael presenting an audit, and then we will also have finance a little bit later in the paper. If there's anything in relation to Michael's presentation or David's presentation, recognising that we are going to be within the substantive board papers discussing most of those issues. But if there's anything, looking around, sorry, I was looking at an auction room look around for a last bit, but I wasn't doing that. But if there is, please, Karen.
Just quickly, if I may. I was just wondering if
there are two I would focus on. First and foremost is, like any organisation, we really need to be resilient in terms of cyber. We've seen the experience of some of the London hospitals where this arose, and it is a national priority. So this is something I think we really need to be absolutely confident about. You can't mitigate the risk completely because it's getting so complex, but talking to Steve and Paul as our NED, the trust is moving in the right direction. But I think we have to recognise it's going to take time, and so that's a difficulty. I think the other issue for me, being an auditor, and there is sometimes a degree of cynicism in the audit mind, forgive me for that, but I'm at one with what Simon is saying. We need to strengthen the control environment here. There are real opportunities to, what I would say, deliver better value for money from some of the resources that the organisation has at its disposal. I think the good thing is that we have a clear plan about how we will do this. So I think in terms of the governance responsibilities of this board, it's about, in a constructive way, holding the executive to account for delivering on that plan. And those are the two things that I would say I would focus on at this moment. But a very good question, and thank you.
Liz.
Thanks, Liz, for the question. I mean, incidentally, our colleagues in Heartlands are coming to our part 2 session that we will do in private, because they are developing. They haven't launched it yet, but the good news is they are developing it with us. So they're coming here today to present the strategy to us and to share it with us. So that's an example of how we will do it. We also work very closely in the partnerships team under Matt's leadership, really to embed ourselves in the system so that they know that we are no longer operating in a bubble, and they come to us for opinion. And we'll see a really good example. One of the papers we have later today is the shared delivery plan for Sussex, which is their year 2 delivery plan. And this is here for us to approve and endorse as a partner to them, that we're signing up to the things that they're signing up to and the part that we will have to play in their system. And that shared delivery plan is, you won't be surprised, very much hand in hand with how we deliver hubs together, for instance, in the coming 12 months. So we do a lot by way of trying to build good relationships with our partners. We have been out and about in the way that we've developed this strategy. Most of our system partners, all of our system partners, have had their voice heard and have had a say, and they would recognize the direction of travel that we're going on. And the good news is we're starting to see that feedback. So what I look for is, do people come to us now, and are they interested in hearing us and the influence of their development of their strategies? The answer is yes. We are very much being asked to look at the shared delivery plan in year 2 as a board in Sussex and approve it. We're very much being asked to contribute, and we're going to have a part 2 session where one of the CMOs at Surrey Heartlands will come and share with us their clinical strategy. And I know, Richard, you and your colleagues are very much involved in all of those clinical development sessions that happened through our normal governance that we set up last year as part of how do we engage with the system in a different way. So it's a multi-pronged approach, Liz, I think, what we're saying. And clearly the job of the board will be to keep this on the agenda, because we know it's one of those things that can very easily slip if we don't keep a very intentional eye on how are we liaising with our partners. And indeed, I believe it's one of the things that we've captured in our new BAF risks. One of our new BAF risks is, do we have sufficient influence and input with our partners in the way that we deliver clinical services in partnership? So I think we have the right mechanisms. It's going to be the job of the board now to just make sure we don't stop talking about it, because that's where we will slip. Thank you.
Paul.
I just wondered if we actually captured the benefits of that and we're telling our system partners about it, because it's a great example of the strategy working in practice.
I wonder if, Emma, you want to come in and talk a little bit about what our clinical colleagues do in 111? Thank you.
Thank you for the question. So when 111 was set up, and we've obviously do that in Kent and Sussex specifically, there was a real focus on our 111 service being a system play. Not only to help manage the 999 demand, and we've got probably the lowest conversion rate from 111 to 999 nationally, but actually the whole way the system is set up to do direct appointments into ED, to have direct access to GPs for booking. It has been a huge success. But the only way we've been able to do that is in collaboration with our ICB partners. A huge amount of work went into, when the contract started, working with GP partners, because there was always some initial anxiety with changes and booking people into appointments and EDs. So it's taken time to embed. But without a doubt, it is a system benefit And it absolutely has been recognised by our acute colleagues, because it means that they can also manage some of the flow coming into ED in a more proactive way as well. So it is something that we are very proud of. We do with Kent and Sussex strongly that this is the focus, particularly around the clinical assessment service and how our multi-agency clinicians, which range from dental nurses, range of nursing backgrounds, GPs, pharmacists, all collaborate together to really support those patients in the most appropriate way, to give them really good patient care.
Yeah, no, it's a wonderful story. I just want to make sure we're telling everybody about it. You know, I mean, do our staff know about this and think it's great? You know, that was quite the question. Was great? It's wonderful hard work and it's brilliant seeing it pay off. But have we told enough people? And you know, the press, everybody should be interested in hearing about this.
I think, Paul, the point you're making is, do we celebrate enough our successes? And I think it's a very well-made point, which we will take away and reflect, because it is very easy for us to focus on the day-to-day that it takes to look after an organisation like CCAM. But I think we'll take it away. Are we celebrating our successes enough?
Yeah.
And come back.
Thank you. And it'd be good to see a board story about the pulling from the stack, because that's another success again, isn't it? Which maybe we don't. I mean, I don't know enough about it, but it's wonderful. Thank you.
Thanks, Paul. I'd certainly agree with that, and I think David and I were just talking about there's a current consultation on the Darzi review. Ara Darzi coming in, I have to say, 2 decades after he last did a review. And we were talking about being able to sort of capture, you can put the figures down, but to be able to capture the richness of how we're doing this transformational change. So that's a well-made point. Thank you. Howard.
Thank you, Howard. So Surrey 111 is currently delivered by PPG on contract by Surrey Heartlands. I think it's fair to say any opportunities that would align with our strategy, being it in 111 or other opportunities, would be things that we may explore in future.
Thanks, Emma. And it's a good point, Howard. I'd also probably add, I think as the strategy rolls, it will be interesting to see how that might lead to sort of further alignments, because that you can see that the further synergies there could be. If there are no other questions, no, there is. Come back, Karen.
Thank you. I welcome, David, the launch of the sexual safety in the workplace strategy, given the importance of this issue. I was curious to find out a bit more about the organisational summit and just confirmation that in Margaret's work that she's getting the support she feels she needs to deliver on this.
Yeah, I think.
Do you want to go first, and then maybe Margaret, you want to make comment?
I think Margaret is our sexual safety lead at the board, should answer.
Thank you. They're playing games today, aren't they?
Yes.
Thank you for the question, Karen. So, yes, very much looking forward to our session, already putting a lot of thought into how we do that, because it's not an easy question that we're going to be asking ourselves, which is what does zero tolerance look like? And it's interesting that the whole NHS is actually addressing that at the moment against racism, etc. So we're going to be doing the same. Do we have enough help? I think we're getting to the point now where we do recognise, and Sarah Wainwright and Andrew and I are working closely on this together now, we recognise we're getting into areas of specialism, where we're having to consider ourselves. So we're planning a session with some specialists for the executives to first of all start really reframing our own thinking and thinking through some of the longer term implications of what's going on in the organisation in regards to sexual safety. Every decision we make could have an output years down the line, which could mean different types of legal consequences for the individuals, for us as an organisation, and put us at risk. So we're at the position, I think, that we're going to have to bring into specialism, and in regard to leading the work, it is certainly fairly full on. And so we are beginning the discussions around how much time as an executive an individual can spend on this, and whether we actually need to have a dedicated resource for it to coordinate it. What I'm really, really warmed about in this organisation, though, is the people that are on board with me and doing the work. So we've got a dashboard just about to be launched. We just need to sign it off of the steering group. We have the communications launch in place now. First podcast's already out there. They are doing it with passion, with dedication. They're doing it on top of their normal day job. And, you know, that's the thing that brings hope and light to me in what can be a fairly dark place. So it's a good question, and we are certainly beginning that discussion now, because it is going to be a piece of work that will need to be sustained for years to come.
Thank you.
And then thanks for raising it, Karen. And do again, we will have, as a board, it must be something that we don't just say, well, it's there, it's off. We do need to be able to come back round. And it also reflects how many elements in terms of the current change programme that we've got. And as a board, being able to sort of keep that oversight and not overly focus on single areas, I think that really comes through. So thank you once again. I'm going to then move us on. And as I say, there's plenty of space to be able to come back to some of the issues that we've already touched upon. But now to be able to talk about both trust values and also our board story. We have board stories, and we're going to connect those in this instance. And I think, Emma, you're going to take us through in terms of talking about the values. Then we're going to see a video, I think, and then it's open for questions. But over to you, Emma.
Thank you very much, Chair. So I'm delighted to have the opportunity to present this today, and Janine was and her team, as well as many other people, have been absolutely key in getting us to this place now with our values. I think it's really important to recognise that the values are something that is absolutely integral to all of us, but they need to be real, they need to be felt, they need to be seen in action. So when this work was started, we were really open and really clear. We wanted to engage at scale with all of our people. Needed to run alongside the strategy development, but it was really important that we listened to what our people told us. So you can see within the paper that's provided, it was really about having a smaller number that had meaning, that were understandable, that were real, and that there was really created an environment of accountability within those values. So individuals got involved, networks involved, we had workshops and within directorates and across regions, and we went from quite a long list through a really well managed refinement process to the top 3, and that's what's presented today. So the 3 that you can see that we have come to, and we've discussed this at board previously, so I know that everyone here has had a involvement with it, are kindness, courage, and integrity. But it's really important we take them both separately and together, because so many times you don't see one value in action, you see multiple values in actions. An example could be a difficult conversation where you need to have integrity as yourself in that conversation, and sometimes have some real courage to raise some issues, but treat the other person you're dealing with real kindness as well. So that's why you'll note that the images that we're using very much show that connectivity between our values. So today is the start, the launch of this journey, which is very exciting. And when we go to implement these and really embed these in the trust, you'll see that there are a number of specific actions that are going to be taken. Whether some of it will be straightforward, will be in signage, you'll start seeing it very much on our branded items, but actually also linking it through the celebrating successes, having an army of advocates, for example. But the challenge for all of us around this table and all of our people is what does this mean to us? How do we live and breathe this? So these are real every day in all we do, so that we can see this in each other and our people can see this in us, and our patients feel that as the values that we live and breathe. So with that, if you're happy, I'd like to move on to the video, and then any questions after. Thank you.
I'm Claire Webster, Programme and Portfolio Manager in the Strategic Partnerships team.
My name is James Trenery and I'm a resource dispatch coach.
My name is Jodie Harrison. I'm a paramedic with the Hazardous Area Response team.
Hi, I'm Aaron Ball. I'm a community first responder for South East Coast Ambulance Service.
My name's Alison Marchant and I'm a health advisor for 111 here in Crawley.
Hello, I'm Andy Collin. I'm one of the consultant paramedics for urgent and emergency care in CCAM.
Hi, my name's Annalise May. I'm one of the senior emergency medical advisors here in the West EOC.
Hi, my name is Ritzel Reyes. I'm one of the clinical supervisors here in CCAM.
I am Sadie Jin Morris and I am the Business Support Manager for Strategic Planning and Transformation. I'm also the co-chair of the Enable Staff Network for Disabilities, Carers and Neurodiversity.
With the development of our new strategy, we've also refreshed our trust values so they better align to our vision, saving lives and serving our communities. Our new values, courage, kindness and integrity, have been developed with colleagues across our organisation. Now the work begins to bring them alive and embed them into everything we do.
So organisational values to me are the cornerstone of doing what we do, the way we do it.
I think that it is important that not only do we have values that mean a lot to us as individuals, but mean a lot to the communities in which we serve.
The organisational values for me mean everyone's on the same team, everyone's being treated fairly.
Organisational values mean to me encompassing kindness, courage and integrity into your everyday life.
It's at the core of everything we do.
Following how we should be treating our patients, not only our patients but also our colleagues.
The way I show kindness, probably through the crews I dispatch on a daily. They are part of my team, and to have a nice rapport with them to make them feel safe on the road when they're driving or with patients, knowing that they've got a free space to speak up when needed.
There's one thing that we mustn't do, and that is group patients, whether that's an elderly person that's suffering from loneliness. You know, that person might just need a quick chat and a cup of tea and talking about her husband Barry that died 3 years ago.
Courage is about being able to step beyond those boundaries, being able to push beyond what you know.
Courage is sort of having the bravery to do the right thing in times of stress and conflict and sort of overcome any obstacles that might present, whether you be on a call or sort of within the place of work in the control room.
Sometimes stepping out of my comfort zone to give patients the correct care and going the extra mile to make sure that they're looked after and they're given the best possible care.
You're not being watched all the time. You're out in the community, and maintaining that integrity and trust within the community is very vital.
And you are always accountable with how you decide with the care of your patients or yourself, or you should always be there to help give a lending hand with your colleagues, especially with if they're struggling with something else.
Integrity, I think, comes above all. And I think it is such an amazing thing that as an organisation we have chosen these 3 amazing values to govern what we do every day for everybody.
We know that those 3 key words aren't just words on a page, they are the way we live our lives, the way we want to be treated ourselves, and we know that collectively that's really good for us as a collective, and ultimately will be really good for our patients.
Thank you very much, Emma, and also obviously on behalf of Janine for all the work that has gone into developing these values. And you can see that there's been a real process to be able to do that. because if you impose them, they're really not going to land, they're not going to work, they're not going to embed. We're now launching this just to also say that from October, board effectiveness review will be framed by the new values. So you'll be seeing the values around the table, around the board table. So we will be actively using them. And I'd also hopefully be able to see a reference to those values. And I think the more that we live those values and we start using them, both in terms of a positive to be able to give recognition where those values have been apparent, but also as a challenge. And I think that comes up with that value of courage, that we have the courage to be able to say that we didn't see that as being exemplifying our values of kindness or of integrity. So I think it allows us to work both ways. And I think we want to be able to see those, and we want to be able to see, I mean, I don't know, you know where you see a good values-driven organisation because you're hearing and seeing it all the time. People reference those values very naturally. I wanted to work in a values-based way to be able to demonstrate kindness, whatever that may be. So it's going to be, again, we will see this and we will hopefully be able to measure as a board how it's becoming more and more embedded in what we're doing on a day-to-day basis, but also how we're using it in management settings, but also in governance settings. So I'm just going to open it up now to be able to see comments, thoughts and reflections on what you've heard. Let me take Max and then Michael.
There we go. Yeah, really welcome this great piece of work, and I think the new values will really resonate across the organisation. I guess from my perspective, I'm just keen to understand the sequencing and timing, roughly top level, for all of these embedding activities, because we don't want to launch them today and they just be words on a screen or in a video. How quickly will we strike while the iron's hot to really embed them through recruitment, appraisals, the branding refresh, recognition, etc.?
Do you want to take that, David?
Yeah, thanks for the question. So we've described the number of activities here, and part of the conversation that we've had is this is not we can't have a rollout values plan that sits separate in isolation from our culture improvement plan or our integrated people plan or from our clinical plan. So I think the trick here will be how we can get collective ownership of leadership around how we bring these to life. One of the things that we do, and I'll let Andrea come in a second, is at our next board development session, we will be looking at the integrated people plan in some detail. And I think we have an opportunity there to understand how we do this as not a standalone, because of course we can kind of plaster the place with the values and give everybody stickers and values cards, but that will just help it ingrain in our prefrontal cortex, so we never forget about them. But living and breathing it, it's going to be a slightly different exercise. And I'm conscious that we can put milestones against how we, what are we going to print, what are we going to give to people, when are we going to have it into the appraisals, all of that. I think we will be able to describe quite easily. I think the job is how are we going to know that we're bringing it to life in the way that we conduct the day-to-day business of the organisation. And I think that's a really good topic that we can pick up at the board development session next month, because we will have a full day to specifically talk about how we understand the integrated people plan, and then what does it mean in the context of the new values. Andrea, is there anything that you want to add to this?
No, just to really echo what David said, and just to say that the other focus at the board development session will be getting everyone's collective buy-in, because yes, we do have to weave these through recruitment and through appraisal, etc. But it's a real opportunity to get everybody on board to help us to shape this going forward.
Thanks, Andrew. And Margaret?
I just wanted to add, so Max, this is an interesting organisation. It speaks, people throughout the organisation refer to the values very easily and very quickly, but it's often used in a judgmental kind of way. And so I don't think it'll be hard. I think what will be difficult, it'll be hard to get the 3 words out there and understood. And Janine certainly has got a full plan for how we do that. I think our job will be to do it in a positive way. And I have to say, watching that video, I felt very moved. And I'm always pleased when I'm moved because it means I'm still deeply human and my heart is still in there. And patients were mentioned so often because this is about the whole way we believe, we behave, and the output. And our output is for patients. So I think seeing more and more of those colleagues talking like that is what good looks like, isn't it?
Very nicely put. Margaret. Michael.
Yeah, I agree, Margaret. I was quite moved by that, and that's a very good sign. So, so the first thing, thank you for all those colleagues who were prepared to be, to come on, because it's not easy. Very much support this. I've just got a question and an observation. First observation is, having been around CCAM for a while, and I know it's all changing, and that's brilliant, we do have a tendency sometimes to revert to compliance. So what you get is an annual appraisal form that has got multiple things. Have you done this? Have you done that? I would counsel a softer approach. It's the quality of the conversation, and what I don't really want I know you're looking at this, Andrew, the performance appraisal, but I don't want a template, the approach. I would be prepared, in terms of a board member holding to account, to see a much softer, holistic way in which this is brought within the organisation. So that's my observation. My question is it too soon? We have the events in November, is it October, across each of the counties for the values, and will this feature in the value awards, or is it too early to do that? And that's my question. Thank you.
Thanks, Michael. I'm just going to say, David, and I'm not sure if Andrew, you also want to come.
I'm looking at Margaret. I think I do think our awards this year will reflect the new values. I think we are using them as an opportunity to shift how we do awards and how we recognise. So yes is the answer. I'm just looking because we don't have Janine in the room today who would absolutely know the answer, but we do. Thank you.
Let's go over to Liz.
Thank you. Just a question from me, I think, on behalf of our patients, is how we're going to communicate, because I think all our patients out there believe our staff are going to be kind, they're going to have courage, and they're going to have integrity. But I think that messaging as a core value, are they going to see it as part of our services? Are they going to feel it as part of our services? And how are we going to tell them that this is what they can expect from a CCAM colleague or service?
My recommendation is, because we're going to hear from one of our plans this year, is how we embed patient safety and experience strategy throughout. So I know we're going to talk about it a little bit later. So can we put a pin on that question, and then when we come to that item, we can explore that a little bit more? Is that okay?
So it's a really good question. I'm glad you're going to bring that back, because, as you say, it works both ways, doesn't it? It should be that patients can say, I had a really good experience that demonstrated kindness, and equally they can challenge to say that actually didn't live up to what I think your values are. So, and we do need to, if you don't communicate it, then our community don't know it and won't be able to access it. Did you want to add something, Andrew?
Just wanted to provide that reassurance that we're very much looking at the quality of the conversation, because we're at the moment, people are just seeing it as a tick box exercise. So we're definitely working to support that. Yeah.
Excellent. Karen.
Just some general comments. Also very much welcome the introduction of this. Thank you for all the work that's been done. I take heart not just from the video, but from the people that I've met and documents that I've been reading, that actually we're not starting from a zero baseline on this. So it's important to remember that the fact these words have come out of widespread consultation are because this is already something that people are deeply committed to. So I think it's important to reinforce that through the work that we're doing, and put as much emphasis on rewarding and recognising where these values are being established already, and we're doing that very well. Just building on the point that David made, organisations change when patterns of conversation change. And I'd very much welcome the chance that a lot of this is also picked up in some of the softer issues around the kind of conversations that we might be having, for example, in the debriefings that people were talking about when they're doing reflective practice, where things might not have gone quite so well. So the question might be framed as, in what situations might we feel our capacity for kindness being compromised? And then begin to get underneath some of those issues rather than just assuming it's something that's located with the individuals. There's something about the environment. Thank you.
Very well made point, Karen, thank you. Just to be able to see if there's anything else immediately, as you've heard, this is going to be something that we're going to see increasingly within board reporting, but also within board seminars and discussions. We'll see it. And it's going to be, as I say, the proof will be to see how it embeds. And I very much take Liz's point that, you know, to be able to see how does it connect to our community and our patients as we roll this out. So thank you very much. Thank you, Emma, for covering a little bit for Janine on that. That's very helpful to have. Talking of covering, we're now in trust strategy, where we're going to be able to have, it would be David covering this, but Matt, you're going to step in and present on this. Thank you.
Thank you, Chair. So the next item on the strategy complements the values that Emma has just kindly talked us through. And to build on the comments that have been made, today we're excited and extremely proud to be launching, sharing and recommending our strategy to the board. As colleagues have observed, the strategy reflects the changing needs of the patients that we serve. We know that the population over the next 5 years is growing. We know that healthcare will continue to become much more complex and that the population is ageing. The strategy results from comprehensive and significant engagement with our people, so 2,000 of our people, and a significant number of patients, members from the communities, and working in conjunction with our partners. And as Liz highlighted earlier on, our ICBs have been fully engaged in the journey throughout, and we'll see that in a separate item later in the agenda. As you'll see within the strategy document that is included within the papers, we have restated and strengthened our purpose being to save lives and serve our communities, and that's underpinned by 3 strategic aims: delivering high quality care for our patients, ensuring our people enjoy working at CCAM, and being a sustainable partner as part of an integrated NHS. These 3 strategic aims will seek to address the needs of our patients and our people and make sure that we are a cohesive part of the 4 integrated care systems that we operate within. Within the strategy, we've demonstrated a clear commitment to providing care differently. We've taken the insights, we've listened to those core stakeholders that I've outlined, and we know that we need to ensure faster response times for emergencies, and we recognise that we need to offer a more tailored response and care for less urgent needs. And we'll be doing that through the application and introduction of greater virtual services and seeking to explore and understand how we can leverage technology to ensure patients receive the right care at the right time. Some of the examples have come up during earlier conversations, but we have some clear deliverables within the first year of the strategy, and I'd like just to touch on 3. We'll be rolling out 5 new unscheduled care navigation hubs in this financial year, and they are about tailoring and integrating our responses to our patients for those more complex patients working in conjunction alongside our partner providers. Stephen is leading on how we embrace new technologies as part of our new strategy and how we can start to bring in some of the new digital opportunities that exist, such as artificial intelligence. And as we've heard, we will very much be investing in our leadership development and our people. So these examples in the first year will seek to bring our strategy to life. And as mentioned earlier on, the strategy is supported by new branding and new visuals that continue to bring that to life, and will be driven and underpinned by the 3 values of kindness, courage and integrity. So on behalf of David and the executive team, I'd like to present the strategy to the board for endorsement. Thank you.
Thanks so much, Matt. As I say, for board members, it's in our last board seminar, we've discussed this, and we've discussed this over time, and I think it's probably worth just making that point that this strategy has not been devised overnight. It's been a understatement. There's been a long period of gestation, and I think that's been very valuable in itself in terms of making sure that we're able to connect with all the stakeholders we need to be able to make sure that A, the strategy is the right one, and B, that it's understood and owned by everyone. I also think the point that was made earlier in terms of other parts of our health system now moving forward with their own strategic plans, I think the fact that we were moved at the time that we did has really served both CCAM but also our wider health systems in good stead, because it means they're aware of what's in our minds, so they're already aligning to it. They got prior sight of it. So I'm certainly, as I have those conversations, hearing back that yes, we know where CCAM's at, and we're aligning what we're doing to them. So again, to be able to see if there are any further questions that we have on the strategy, because at this point, as I say, we've previously approved it at the board, but we're at this point, it's supporting the rollout of the strategy. So is there anything further that colleagues want to make? Much you can, please.
Thank you very much. Fully supportive, great work, comprehensive and focused. I just wondered, and you may already be thinking of this, are we going to have a strategy on a page and also a roadmap across the 5 years? One of the challenges with implementing strategies is the number of pages and remembering by everybody. So I think those two things might help. Thank you.
Yes and yes is the short version. So Jenny's not here today, but credit to her and her Commerce colleagues. There's a full rollout plan that will, following in today. Tomorrow we're going to be kind of press releasing potentially some news coverage, and then through next week updating our website, which has already started to be updated, with giving colleagues access to not just the kind of public-facing version of the strategy, which we have here, but also a lighter plan on a page, which will also be included in the materials. The other thing, just to build, just once I've got the platform, is one of the conversations we're having as an exec team is what are those enabling strategies that we will be bringing to the fore this year that will have a specific bearing on helping us deliver the strategy. And obviously we know that the clinical strategy is being developed. That's essential to how we look at the future, but there will be other strategies that we will be bringing to the board over the next 12 months to support that. And what I like to call strategy hygiene is, can that be very clear to the public and to our partners and to our patients, to our colleagues? As you go into a website, you can see what is that we're trying to achieve, not just by a clinical trust-wide strategy, but the underpinning strategies that sit under that. That's all what's in the pipeline. Thanks for the question.
Michael.
Yeah, Matt and David, thank you. Really endorse the strategy. So I'm going to ask two questions. So please do not think these are taking away from the importance of the strategy, because I think it's exactly right. We live in a period of significant change. So I just ask you if you could, and this is a difficult question, if I'm a member of the public, I don't know, Tunbridge Wells or wherever I live, you could say the NHS has got strategies coming out of its ears, right? So my first question would be this. What would you say to one of our constituents who rely on us? What's going to make the biggest difference to them in their lives if they call on CCAM for support? And the second question is this. We now have a government with a significant majority that is really looking at the future of the NHS. The chair referred to Lord Darcy's report that that we look forward to hearing. What would you say to the system and government that why this strategy is supportive of what they are seeking to achieve? So two constituencies that are very important to us are patients, because I think I think I know the answer, but I think it's worthwhile saying this in a public domain.
There we go. Thank you for the question. I think, as we've discussed and presented to the board previously, we know that Our existing model, we respond physically to 90% or thereabouts of our patients that make contact with us. However, when we look at clinical outcome, we know that only around about 13.25% of those patients required a physical response. By sending an ambulance to see if you need an ambulance, actually that results in delayed care. And actually we also know that that can result in avoidable conveyances to hospitals, which then has a significant impact on the patient experience. It delays potentially the interventions and the appropriate clinical care for that patient. And it also impacts on the effectiveness as to how the systems are operating and how we can respond to other patients. So for members of the public and within the communities, what has resonated is that we at CCAM are now looking to align our skills and our capabilities as an organisation with the needs of our patients. And we're doing that through two approaches. And this is not a two-tiered response model, but it's making sure we get the right response to the right patients at the right time. So for patients that are experiencing emergency concerns, we will offer and provide a standardised response that is consistent. If you have a stroke, if you have a heart attack in Medway or in Guildford, our response to you will be no different. We will ensure appropriate timely care that is fast and prompt and get you to the onward facility appropriately. But what we recognise is for those lower immediacy but often quite complex patients, it's not often appropriate or most effective to ensure a standardised response. We know that the evidence now indicates that the closer we can get to the patient and the closer we can wrap around localised integrated care around that patient, the better the outcome. So one of the core components of our strategy is then looking at how we can offer a virtual response that is integrated through a multidisciplinary approach to make sure that patient is being cared for by professionals within their constituency or their local area, and that we promptly intervene much earlier on, so before we even send a physical response, to ensure that we provide access to the most appropriate pathways for that patient. We know that that will improve clinical outcome and be beneficial for the patient. You mentioned the ongoing DARSI review. We have had the opportunity this week to contribute to the DARSI review and we are in the process of returning our submission. As a sector, we recognise and we are part of a number of groups as part of the Association of Ambulance Chief Executives that the national model is strained, it is challenged, and what we are able to do is to demonstrate as perhaps a trailblazer where the ambulance service perhaps should be heading and working with colleagues nationally as part of that review to look at what care needs to be tailored for those lower acuity patients versus how we best standardise and deliver high quality care to all patients that we service. I don't know if any other colleagues want to add.
And incidentally, to a patient in Tunbridge Wells, I'd say our MTW, one of our hubs, went live a couple of weeks ago in its new guise in Paddock Wood with Cupboards in partnership with Maidstone in Tunbridge Wells. So I would hope that patients who are calling us around that area would start to see a difference in the type of response that they get and the type of integrated care that they're able to receive as a result of working with partners, as a very practical change of things that should start to shift this year. Thank you.
Margaret.
And just wanted to link health inequalities with that. So, you know, the actual question, the principle of the question is absolutely right, isn't it? Which is that we will be monitoring and evaluating. And as we bring in our health inequalities thinking more and more and more in our tools that are slowly being built up through Julie and Richard's team, we will be looking to ensure that regardless of where you are, there's parity in response and therefore in the outcome.
Thank you.
Karen.
Thank you. Welcome the excellent work, and it's interesting coming to it as a new member. And I found the documents extremely comprehensive and easy to understand. So thank you for those that have been involved in producing that. I noticed a couple of assumptions that seem to underpin the strategy overall. One that's been mentioned is collaboration with others, and the other is around resourcing. Do we have a plan B if either of those don't come through in certain areas, and how are we planning to deal with that?
I'll attempt to answer and then see if other colleagues want to come in. We've just about presented Plan A and you're already asking about Plan B. Gosh, give us a chance. So we presented options and part of the journey that the board has gone through is looking at what are the different options. So in a way, I'd say plan Bs would be the options that we discarded. But now we need to remind ourselves there was very good reasons why we discarded options around, doing just ambulance work and not integrating, not collaborating. So kind of discarding the care navigation. That would just damage the system. We need to be a system partner. That we heard that very loudly from partners. I see no indication that the narrative or the direction of travel or indeed what's right for patients will change. I expect that some of the reviews that are ongoing will turn out some of the emphasis in collaboration and partnerships as a way in which the NHS as a whole moves forward. So I think I would suggest there isn't really a plan B. We strongly believe that this is the right direction of travel. What will require is not all the things that we will do will work first time. And that is, I think, the important principle that kind of underpins the strategy, which is the way in which we shift our clinical model. We may do these hubs this year and actually do one of the big things we're doing is a big, strong evaluation that we will be looking to bring back to the board towards the end of the year. Well, some of what we do this year may not work. And that's okay. And I think part of having courage and integrity is being able to say, well, we tried it didn't work. Here's some stuff that did work. But, what have we learned and what can we then embed for year 2? So I think, I don't want to say there's a plan B. I think what we need to be is not afraid of enacting plan Bs as opportunities come along, because there may be very good reasons why we need to enact plans B, and the strategy should not give us a blueprint or a diagram of this is what the answer looks like, but it's a true North Star in a direction of travel that we want to pursue. And then there's a lot of roads to the top of the mountain.
I like that challenge, Karen. Thank you. Richard.
Just on the back of what Karen was asking around collaboration, and David, thank you for introducing that. I think what you'll find when we come on to talk about some of the detail around the clinical strategy in the presentations a bit later on, particularly around hubs, but also when we hear from the Sussex overall ICB strategy and the Surrey ICB strategy, you'll notice that they're all saying exactly the same thing. So in terms of a plan A, if that goes wrong, it's going wrong for each system, including our plan A. So I've got great confidence that we're all thinking the same thing across the system and across the systems that we work with in working up these plans. And I agree with David, it probably won't turn out exactly as it's written now, but I'm confident that with the clinical leadership that we've got in terms of our plans and our relationship with our system, senior clinicians and senior operational managers and back office staff, that as we move along in the rollout of our strategy, we'll be able to tweak it to make it work for patients, which perhaps in the past we weren't able to do because we didn't have that relationship with our partners.
I think that's very, very helpfully put, Richard, and I think to provide further reassurance, Karen, that it shows that there is that flexibility of evolution around the basic principles of the strategy. Matt, did you want to add something?
It's just to say, I'd go as far as to say that the strategy has allowed us now to be recognised as a UEC system leader across the 4 integrated care systems. The discussions that we've been having, our strategy has brought together partners to look at how we enhance whole system care delivery within urgent emergency care. And there's already fantastic examples of collaboration off the back of our trust strategy, such as the hubs that Richard just touched upon there, and the fact that we have every ICB and strategic provider partner around the table working with us to look at how we adopt and implement these for the winter and the future model beyond. I think your second question was around resourcing. I'd just like to offer reassurance that one of the reasons we went with this strategic option is that we don't need to look at significantly increasing resourcing. Actually, this is around alignment of capabilities. So we recognise there is a misalignment, there is a gap between the patient needs that we're servicing versus the capabilities that we are responding with. We need to look at how we best align the two organisationally, but we don't envisage that would require a significant uplift in workforce, and over time, actually, we could look at how we enhance and effectively deliver care with more efficient resource.
Thanks, Matt. Mindful of time, I don't want to stop any discussion. We've got Liz and then we've got Howard.
Thanks. And a question from me is around that 24/7 service. We know that ambulance trusts and A&E is the only true 24 24/7 service that's available. So I think are our hubs going to be working through core hours as we've trialled, which is that 8 to 6, 9 to 5, because integrated care pathways aren't available outside of those hours, and how we're going to manage that. And I guess the appetite from our partners to have alternate pathways, because again, I think if a patient rings at 10 in the morning or a patient rings at 10 at night, the response and pathway is going to be very different. Emma.
Really important question to ask, Liz. I'm going to hand that to Emma, I think.
Thank you, Liz. And it's a really valid question. You're right. There are only 2 doors open 24/7, 365. But I think what we need to do is also recognise that the way that we support and care for our patients needs to change in terms of, it's very important we get to some people within minutes and seconds. The question for me is, how do we become part of that patient flow and case management? Because it may be that we go to somebody and we pick them off the floor at 3 o'clock in the morning. It doesn't mean to say they need a referral at 3 o'clock in the morning, but at the moment, our case management has to close at that point. So the challenge for us, I think, is less about the acute, is more about the more urgent care kind of patients, to say, do you know what, you do need a pathway, and I get the fact that you need X kind of onward support. Just because it's not available now at 3 o'clock on a Sunday morning shouldn't prevent us saying, but you know what, at 9 o'clock in the morning, we can pass that information on. That's what some of the things about working with our urgent care colleagues is about. Ambulance services have historically not been set up for I'm going to call it holding on to patients beyond the end of their acute treatment phase. That's part of the challenge for our hubs, is how to actually move. I don't think 24/7 hubs is the answer. I think the challenge for us is how we become an integrated partner to say, I've been to you at 3 o'clock in the morning, I'm going to refer you on, but it won't happen until 9 o'clock. Or if it happens that night, the following morning. It doesn't mean it's unsafe, it means it's still the right care, the right treatment for this patient, but it allows us to operate in a different way to that which we've always done, which is very short-term, episodic, rather than being part of a bigger case management system.
Very helpful nuance. I'm going to take Howard now. I'm not sure if, as you were speaking, Howard, you saw that the heads nodding, but there were a lot of heads nodding. So I don't know if there's anything immediately to come forward for. Obviously, it's a point of reflection, but I think a very helpful one. Do you want to?
I think, as we've confirmed, that we absolutely are developing that one pager. Within the strategy, we've looked to, at a high level, describe in detail how this service model will benefit patients, will support our partners, and enhance the experience within CCAM for our people. But take Howard's point, and we'll ensure that we further describe that within the additional documentation that we'll be publishing externally.
But Barry, I think it's a really good reflection. Thanks, Howard. In page 11, I think we attempt to do that, and we'll make sure it comes forward. But I'd have 3 very simple messages for anybody in the public listening, which what your local ambulance service is trying to do is be very reliable when you really need us. If you've got a stroke, cardiac arrest, any form of emergency, acute emergency, we will be there for you in a much more timely way that we can do now. And if you have another unscheduled healthcare need, we will be playing not just as an ambulance service, but as part of an integrated care system to help you get the right care that you need. And that's what we're fundamentally putting forward to patients today.
Thanks, David. I'll just look around again. I think we've given a very good area, and thank you, Matt. You really did sort of encapsulate it very well, and I think it's very good for public record for us to be able to do this again. And I would just maybe, in just summing it up, the two elements, I think, and I like Howard. I like that sort of two sides, two parts to the one pager, because I think one part is just to be absolutely assured that this is not transactional change. This isn't just about tweaking one part of the system to be able to do something. This is transformational for us as an organisation, but I think more widely for ambulance services, and we need to recognise that in all its glory, but also in terms of some of the challenges behind it. But equally, I think the second half of the A4, if you like, is around that hearts and minds. And I always go back to Saturday night BBC One television sometime around 8 o'clock when someone calls 999. And the way that the television is cut, the ambulance turns up about 4 seconds later. And I think that's where the public mindset is. So what we need to do is to be able to win the hearts and minds part of it, to be able to say your most excellent care could be hear and treat. No one is going to turn up in a uniform outside your house in 4 seconds or even 4 minutes, but you are going to get the very best care that CCAM, the ambulance service, can provide. And I think that hearts and minds part, I don't think we can underestimate the challenge to be able to get people used to it. And I just certainly reference my work in London around primary care, when we got so many aspects of primary care right, the patients were saying, we don't like telephone consultations, and we hadn't done that part to be able to show that telephone consultation could be the very best type of care that you can get. So we need to be able to do that alongside it. Excellent. Right. Now we're going to, we have 3 parts. Minded, I was looking to see whether we can get a break or not after we do the first element, which is we deliver high quality care. And just again to remind colleagues, this is this iterative process where we're going to, it will look different by the next board meeting, but this is where we're going to sort of start walking through connecting the strategy, connecting the values, and being able to connect the governance from what's happening at the board, what's happening out there in terms of how the executive lead on this, and also in terms of committee oversight of what happens. So we're going to we deliver high quality care first, and I think, Margaret, you're going to, we've got a twin track between, I looked over and it said, in terms of how Liz will present and then Margaret will present, and I think you're going to run with us first.
I think Margaret first.
Margaret first, then Liz.
So Richard's actually going to be our conductor, but I'm just going to start on the first slide. So you'll notice in these papers, and it really is iterative, so we would really value some feedback from ourselves as well as from you who are listening to this presentation and then coming in with questions. Because there's quite a lot in this pack, isn't it? It's quite dense. And what we want to be able to do is highlight and put a light on the areas of real importance that are being met, so going to Paul's point where we can celebrate, but those areas that are also slipping or causing issues. And then there'll also be occasionally things that aren't captured here that we will want to bring to your attention. So for the quality improvement, I'm going to start only because we've got a summary page there that is mostly reflected in the portfolio, and then Richard is kind of going to direct us through. So To link this to the IQR, there are no exceptions to highlight from the quality and safety section in the IQR. But I would like you to note that work is happening now between the patient safety and the BI teams, and also the medicines management and the BI teams, to develop metrics that better reflect now for the patient safety is the move to PSERF. So you'll note on the metrics for the number of SIs, for example, that's dropped down tremendously. Well, you'd expect that because we now no longer have an SI framework, so we don't report SIs in that way. So we need to come round the loop. The conversations already began to see how we can reflect the principles of PSERF so we can see what the situation is with regards to patient safety. In regards to medicines management, what they realised that, for example, in the metrics of CD breakages, the line for ambition is 0. Well, we're humans, so there's always going to be some CD breakages. If you have any paramedics like Margaret Yell was a nurse, believe me, you'll get a lot of breakages. So clumsiness was my name. So that needs to be reset in a way that's realistic so that we can start seeing some statistical improvements. At the moment, we're not able to demonstrate any statistical changes, which makes it look like we're not improving or maintaining a good position, whilst in fact, Richard and I have gone through all of these in detail, and we have got some really good stories in some of that. For example, the cardiac outputs that we're just not showing because we're not reflecting it well. There is a graph that you'll notice the harm incidence per 1,000 incidents that could cause a little bit of alarm. There's a drop on that graph, which could look statistically significant. However, with PSERF, and this is a good example, harm is not allocated until the very end of the process. PSERF is not a harm-based approach. So therefore, there's going to be a lag. So what you'd notice if we carried on with these metrics, in the months to come, those numbers would change for April, May and June. And you'd wonder why. Well, that's the reason why, because they're being allocated retrospectively. Hence, we need to do that work. One piece of celebration that I wanted to bring to you. You'll notice in the BAF that there's a number of QI projects taking place, which were the priorities that we set as a trust. Last year, we set safety in the OC waiting list, or safety in the stack, we used to call it, as one of our priorities. We've been working closely with Cleric to get some of these improvements put in. And in July, we actually did get one of our automated text message plans in place. I hope you've noted and really feel pleased that just within 1 week we're seeing significant benefits in areas outside of what we expected regarding the welfare calling element, which has released 300 hours saved in 1 week in welfare calling, and that was week 1. You'd expect it to improve. 22 hours saved in call handling, 15 hours saved in closing duplicate calls, and 450 cancellations received. That is really good news, because that's where we're going to start seeing the effectiveness, but also the impact on our welfare callers. With less calls, less pressure, there's a little bit more relief in your day work, isn't there? So really thrilled with that, and hopefully as the year goes on we can bring more and more good news stories. But it's a testament to the board who invested in a team that came into force just 1 year and 1 month ago, and the impact they're having across the organisation. I'll hand over to Richard now. Thank you.
Great, thanks, Margaret. So we wanted to bring to your attention 3 important areas from the quality subsection of our strategy and BAF. I'll cover 2 of them and then pass back to Margaret for the last one. And you'll notice that a number of these things we've already talked about, so I'll cut them short in the interest of time. So for the first one is our unscheduled care navigation hubs, which can be found on slide 13 of the 49 slide pack for the BAF paper for this section. And as we've already covered in terms of our collaboration question and the discussions we've had about working with our system partners, we have got a really ambitious programme to get year 1 of our strategy looking live and going live with our first hub by October. And this has involved significant work from Matt's team, our clinical leaders in the organisation, but also the clinical leadership across our provider partners and our ICB. And we're confident that the first hub will go live in Surrey. It will be a virtual hub rather than a physical hub in October. And there are weekly joint meetings with our system partners to ensure that that goes live on time. The important thing to remember from a patient's perspective is this is all about what we've been talking about all morning in terms of getting the right care to the patient at the right time, not necessarily an ambulance turning up at their front door. And so this is involving clinicians from our own service working in the hub, but also clinicians from our partner organisations working in the same hub, working together to try and find the right place for the patient to be treated, or indeed managing their condition on the telephone. In terms of risk, I was asked this question by our ICB partners only this week. Richard, what's the thing that's most worrying you about this element? And I think it's important to share with the board that I think that the pace that we're working to get this live by October is our biggest risk. Particularly when August, there's lots of people off on holiday and the pace starts to slow a little bit around August. So getting this live by October is a significant challenge for all organisations involved in this. But I'm confident that with the partnership working that we've got a really robust plan to go live with the first one in October. The second element I just wanted to touch on is on the next slide, 14 out of 49, which is our clinical models and pathways of care. We keep changing the name of this based on feedback from our staff who say, actually, no, I think we should call it pathways rather than models of care and so on. We will come up with a firm name and use that going forwards. But essentially, we've got 11 of these. And what we've done is we've taken our patient groups and split them into their health conditions. And there are 11 different health conditions that we're working to. And much the same as a conversation we've already had, we can't make any of this happen on our own. If we take dementia care as an example, there's no way that we can provide extensive pre-hospital dementia care on our own. This is a pathway of care involving our mental health colleagues, our GP colleagues, the acute trust colleagues and our commissioners. And so we've got a lead clinician for each of the 11 models of care who are working with their opposite numbers in the ICBs and in our partner providers to design pathways that we think will be the best thing for the patients within that group rather than what our respective organisations can already deliver. So we're being very ambitious in what we're looking at. Again, there's an element of risk involved in that because we can say what we think is the best design for our patients in that particular health need group, but there may be different views from our partner organisations, and then we need to start talking about funding models and commissioning models. As David touched on earlier, this is very much dependent on our system leaders, our ICBs really driving this. And we've got an excellent relationship with our ICB in all 4 areas. And they have introduced, as you'll see when we come onto their strategies for Surrey and Sussex later on, they are introducing this as well. So they want to work with us and they want to work with our other providers to have one joined up pathway for each of the different health conditions that we cover. So really exciting work, and we'll keep you up to date at the next board meeting with progress against that. I'll now hand over to Margaret to cover patient experience.
And in fact, that made me reflect a conversation we had last week with Medway, who want this a week ago, not in October. Thank you very much. As that shows how joined up it is. So the patient engagement experience, our strategic ambition is that we'll have the strategy, which is one of the enabling strategies that will be required for the overall strategy. We'll have the one that will cover 2025 to 2030 by the end of Q3. So key achievements then against that. Connected to it, our quality accounts, we did publish them in June. We have connected with a number of organisations now that are the minority, the harder to reach, the harder to hear communities. And this relates, Liz, to the question you asked earlier, which is how do we start letting patients know what to expect? It is with those connections. So we've reached out to BAME, LGBT groups, VCSC organisations, far and wide now across all 4 areas to start getting some feedback back, but also to get some information out. Our community forums continue, and a risk associated with all that is this is a team of 2 people within the portfolio, and at some stage, so this year we will be running it with 2 people who also hold the quality accounts for 3 months of the year. Actually, things are put on pause for patient engagement because we're doing the quality accounts. Next year, I think we can expect to have a discussion around how important and valuable is patient engagement, which of course it is, and therefore what resources are required for that. But for now, the amount of work we're getting through is quite phenomenal, and the feedback we're beginning to receive through the patient experience experience questionnaires is increasing month on month. So small numbers. Our target was to get 100 responses a month, which doesn't sound a lot when you think about the number of incidents we go to. But if you think about the nature of our work, it's a pretty tough gig we're in there. But we are getting month on month, and we really rely on our operational staff in giving out the little cards or just making sure they're available in the ambulances and in other areas. We are undertaking a gap analysis over coming months now to really assess our position, to see where we are reaching, where we're not reaching. And I think in that, I'll throw the challenge that you gave as well, which is how do we now thread the values through it and some elements of our strategy. I think that's all I wanted to say on that one. Thank you.
Thanks, Margaret, and thanks, Richard. I'm trying to work out how best to allow the sort of discussion, because we've also going to, just again, we have this reporting system, but we also have the Quality Committee report. I'm minded actually, sorry Liz, just to be able to ask for some sort of, maybe not to talk about the committee itself, but to give some comment on what you've heard already, because you are the central engine room governance-wise in terms of taking this. So I think to be able to help us in terms of giving us a pointer, and then I'm going to open it up for question and comment, if that's all right.
That's fine, thank you. And I think both Richard and Margaret and our clinical teams feed through to that Quality Patient Safety Committee, and we're really looking forward to having Jackie on board as our Chief Paramedic as well going forward. And I think we request management responses as all committees do. And I think there's also an area of escalation for the exec to bring forward to that committee where they feel the need to do that and where there's also a requirement for additional support. I think the escalation report is there as read. I'm not going to go through all of it. I think I just want to highlight a couple of areas, if I may. One is around right care, right person, which Richard leads on. And just to say, all our counties, police forces have now rolled this out across the patch. We're monitoring closely to make sure there isn't a huge amount of additional demand on our ambulance services around that. We aren't seeing it at the moment, and the police forces and ourselves are working very closely together, but we will continue to monitor that. I think the other area coming through was around our staff survey and feedback, and I just want to demonstrate linkage. There was anonymous comments in our staff survey around concerns of the way we manage deceased patients. That concern was taken really seriously, and a look-back exercise was put in place. And the look-back demonstrated that appropriate care was given. However, perhaps where we lost our learning was in that feedback loop. So we're now going to include that and that development as part of our new learning framework. So I think it was valuable feedback from a member of staff. We've looked at it, and we can improve how we feed that back to our service. I think other concerns was, we're all aware we removed our private ambulance provision from the 1st of July. Again, we're just monitoring that to make sure there isn't any delay in responding to our patients. We were assured around the cover of that, both from David and from Emma and the team, from our workforce and our hours on the road. We haven't seen any tremendous impact, but it is the summer. So we will wait and see what the winter brings, but we will continue to look at that. And just one area of real progress that's been made by CCAM and now been taken up across the ambulance trust is around acute behavioural disorder. A huge piece of work has been done on this, and that's shown that we're one of the leading ambulance services in the clinical areas, and this is also contributed now to a national consensus document. So really well done to the team who've worked on this and made a difference nationally around that. And the rest, any questions I'm happy to respond to.
That's so helpful, Liz. That's very, and because what's that is allowing us to do is to be able to see how at committee level this work theme of we deliver high quality care is being driven through, and the issues that are a particular area of focus. So what we can now do is that we have the elements in terms of what Margaret and Richard presented on, but also within the context of what Liz has been able to give us in terms of what subcommittee oversight there is. So what I'd suggest is that there could be questions that colleagues would have. I'd also be interested to know, I tested them, went through it and took some various themes and be able to see, right, can I follow an audit trail through to be able to provide assurance on, say, see and treat levels or whatever it may be. And I have to say you can do it, but it's a little bit of a moving forward and moving back. So both to be able to ask questions, make comment, but also to be able to make comment on how this is working, to be able to allow, especially ZEC colleagues, but also to be able to reflect on how we can take this as an iterative process. So if I frame that, I'm now going to see, I'm going to take Michael first, and then I'll take Paul.
Thank you. It's very clear from all, and thank you, Liz. I suppose you asked the first question, Chair, around the linkages. So ultimately, what we're about is patient outcome. And the way I read it is, it's a bit, I don't know how we do this, it's incredibly difficult, but I do sometimes think we need to start with patient outcome rather than look at what is essentially input and process. So I'm used to a form of analysis that would actually say, are we meeting what we want to do for patients, and then work back to understand if we're not, what is the reason. It's just a preference in my mind, but I can understand how difficult that would be. So that would be my challenge. My question, and again, you have to recognise I'm not a clinician, but I was just looking at the page in the integrated performance report on outcomes around stroke care, and it seems to be that there are a lot of moving factors there around the introduction of telemedicine and other things. And I just wanted some assurance. Are we confident that for that condition we are delivering the best service, or are things beginning to change that might put that at risk? I'm assuming telemedicine could help us, is that right? But could you expand a little bit? Because the way this comes across in the integrated performance report, it comes across more as an issue. Is it an issue or is it a benefit?
Thanks, Michael. Let's hold on that immediate one, and then let's loop back again to the wider point you make.
Shall I cover the stroke element of it? Okay. So we've included stroke as part of our quality account priorities for this year. So you're right to draw out that we think that it might be an issue. Not that we're necessarily delivering poor care for patients with stroke, but we think we can do better. The element of the telemedicine is being introduced nationally. And so we're part of that programme of rollout, and it's intended to take the patient to the right stroke hospital. Okay. In the past, you used to take a patient that was having a stroke to the local district general hospital or the closest hospital. Now, with specialised stroke care, with specialists in particular buildings and not in every DGH, we're supposed to consult with the clinicians in the hospital before we take the patient to that hospital. Okay. That, in theory, could extend our on-scene time and could extend the time that we take to get to the hospital, but ultimately the patient should get to the right hospital and therefore receive the right medium to longer term care. And the data suggests nationally that it is having a positive impact in terms of patient outcomes. I can loop back on the patient outcome question if that would be helpful as well. So as part of the 11 models of care, you're right, as a service, in fact, as the NHS, we're rubbish at modelling everything on patient outcomes and actually measuring them, analysing them, and then holding ourselves to account against patient outcomes. We're pretty poor, particularly in the community, particularly in ambulance service. And so as the development of the 11 models of care progresses over the next year or so, the clinical leaders are given the objectives, if you like, of designing their models of care around what we think patient outcomes should be. Now, I say think because we don't always get that data to be able to help us with that information. Often when we drop the patient off at the hospital, that's the last we hear of them, and we don't know what the outcome was, and it's hard to measure and it's hard to get that data back. But we're trying to change the narrative in the design of the models of care around looking at patient outcomes first. So I completely accept your point that that's the way to do it, rather than design the process and then try and work out what the outcome is afterwards.
If I may, just one response. So, given my previous life, and I've seen health models in other countries, I think what we're not good at here, and it's not a criticism of CCAM, it's a criticism of the NHS, and it's interesting the reforms that the Secretary of State wants to begin to develop. I'm really, really interested in what is the cost of that outcome, because I think that should determine resource allocation and how resources are deployed by trust. So what we tend to monitor in trusts is our inputs, not our outputs. And until you get into that, we are not going to drive some of the improvements in efficiency and effectiveness. So I would encourage to look at the combination of quality and cost and outcome. We got a discussion this afternoon on clinical strategies. I haven't seen yet any clinical strategy that has linked cost and outcome and a resource. And I think the ICBs need to grapple with that quite soon. Anyway, thank you.
Margaret, you wanted to...
Yeah, I just don't think we should underestimate. So I think quantifying outcome for an ambulance service is really, really tough. It's really difficult. And for some of the reasons Richard has just stated. But of course, by running to targets, we're actually talking about quality. So I always say to people that I'm as interested in the C2 and the hear and treat targets as anybody else, because they are based on the best outcome for patients. So we know the quicker we get there, the quicker we make decisions, the quicker we intervene, the likelihood is the outcomes will be better. And that's where the strategy becomes important, because at the moment we're not intervening in the right ways. Taking everybody to hospital can often be the most dangerous thing to do. So I know exactly what you're saying, and it's a real challenge for us, and we've grappled with it over and over again. But of course, when we set a target, and the targets that are set are based on, so that 4-hour target in A&E was based for an absolute reason. We know every hour over that hour is causing harm. And the other thing to say is P7 has made it much harder, because we used to use harm as the denominator of an outcome, and now we don't even have that either. So all in all, we're making it a bit fussier. But I think it's something we need to carry on striving for.
Thanks, Margaret. Howard, I'm going to bring you in, but I think Paul...
There we go. Yeah, mine was around the biggest risk that you highlighted, which was the lack of a multi-year plan. And I just wondered, what the implications that had, what impact that was having on us delivering the strategy, and what mitigating actions we're taking to address what is our biggest risk.
I think it's clear what we have here. I think you're referring to the to which risk ID? Can you just so I can 537. So this is there's a connection clearly of our ability to deliver a clinical strategy is inherently tied to our ability to become sustainable. So there's a bit more. We'll talk about it, I think, in the third section of the agenda, Paul, if that's all right. But one of the things that we are trying to link together is that connection, that these models of care, and I'm going to try to make a 3-step connection for us, which is we cannot possibly transform by ourselves. We've described the model that doesn't work if you look at CCAM as a bubble. The models of care describe our view of what this could look like for patients, and we've literally now started that work in collaboration with the region. So we're doing this with regional support and with ICB support around what is it that core offer then looks like? How would we go about implementing that model? And we can't deliver 11 in one single go, so which ones are we going to prioritize? Now, if you think about that over the multi-year plan, it gives us a set of assumptions of what we can reasonably expect. We will be able to shift it. The dial will be only shift it at the speed that we shift what's happening in the system, what's happening with strategic commissioning. Those assumptions need to feed into our multi-year plan assumptions, because that will have an implication for our clinical workforce. Matt has described how our workforce needs to change. We need to equip them with different skills. We need to be able to do things differently. We need to understand what that means for technology. So it is quite complex in the way that we're doing it, but this is why models of care is coming forward as a priority, and indeed a tier 1 priority for this year, because us being able to work with the system to be able to agree those models of care and then understand what does that mean for strategic commissioning is where we are focused at, and the outcomes of that, if you want, the assumption outputs, help us agree a credible multi-year plan that we can sign up to with commissioners. Because otherwise, this will just become a conversation around what can CCAM do. And of course, CCAM can do a lot of things, but we can't fix the entire challenge by ourselves. And that has been agreed and accepted by commissioners. And indeed, the work that we're doing at a Southeast region level with the region around how we look at strategic commissioning in a different way. So it's a really good question. It ties in. This is why you see these two risks. One talked about clinical strategy, and there's another one which is more financially focused, but the two are connected and linked by the models of care.
Yeah, it's not an easy thing to fix, is it? But getting our story right and actually telling it is really important in this area, I think.
Thanks, Paul. I'm going to
I think it's a good suggestion, Howard. We'll take it away. We are looking to recast the IQR to look slightly different in the line to the strategic themes by October. I know we talked about a number of reviews, so we will include that suggestion, Howard. We do look at it and we do receive it. It's part of the IQI's national submissions, so we can bring it back here. Thank you.
Karen and then Modjkan.
Thank you. Some general comments. If I've read your work correctly, my understanding is this is fairly new and it's in progress, and you're welcome feedback. So my initial feedback is I was very heartened by what I saw. So thank you very much for that. As a non-exec director, it's extremely helpful to have some proper statistical analysis of the work that we're looking at, and also that you're drawing that out with quite comprehensive narrative from both of you about the significance of that for us to take account of. So that's extremely helpful. And I think if you're new to it, all credit to everybody that's been involved to get it to this point. So thank you. Yes, there are some points of perfection that we can discuss at committee level, but I think we can do that in detail. More generally, in terms of echoing some of the themes that have come out and just adding to those, totally agree with our striving towards the importance of looking at patient outcomes, recognising we're not unique in that. And it may be that we want to start leading the way in some of that in terms of some of the evaluations of the specific pathways that we're doing. And I guess there's just a general thought to put out about the pathways is, as well as the content of the pathways, it's thinking about the design and what we can learn about how to do that, and making sure that we set up clear evaluation methods at the beginning so that we're collecting data all the way through, and doing that in collaboration with other places that may be working on similar pathways. And I imagine you're tapped into all of those networks, but often that's the bit that gets forgotten when we start off, and then you end up with process as a proxy measure rather than looking at the outcomes. So would appreciate that. The other is Margaret's point on harm reviews. I do think that's an area more generally that is quite weak nationally in terms of the sophistication of the tools themselves and what they're designed to do. So that might be something we want to think about in terms of how we capture that, and maybe get involved in, if there are opportunities nationally, to try and develop that, because I'm not convinced that that's something that's is quite where it needs to be at the moment.
Thank you, Karen. I'm not sure if anyone wants to, very, very helpful points to be able to make and reflect. If anyone wants to make any comment on that, Matt.
I think just to offer some reassurance to the board, it's been recognised by all 4 integrated care boards and their systems that this will require a significant change to clinical culture. What's really encouraging is we're now part of different types of collaboratives within the 4 integrated care systems at a community level to look at how these pathways will be delivered and what our collective desire and vision is as partner providers. As an example, within Kent and Medway, we're part of a collaborative that is focused on mental health. We are supporting the crisis care approach and learning disabilities, and then recognising there are different population health requirements and needs across our footprint. In Surrey, as an example, the focus is on high-intensity users and frailty. So it's just to offer reassurance to the board that this is timely with our strategy implementation, because those provider collaboratives are now starting to come to life, and we are very much around the table having those discussions. The second point is, as I mentioned earlier on, we are part of the National Ambulance Strategy and Transformation Group, and there has been and continues to be a benchmarking exercise ongoing, looking at pathway ease of access across the various ambulance provider organisations across the country, so that we can share learning and look at how we can best support our staff and clinicians within the contact centres and within field operations.
Thanks, Matt. And David, do you want to come back in?
Yeah, and just to close the point on evaluation, because I think it's very important. One of the things, and I quite like the continuous evaluation descriptions, which we've put at the heart of the hub. So my expectation would be that from the moment these hubs go live, we've agreed a framework for evaluation. I think that would be something that would be really good to kind of bring back through a Quality Patient Safety Committee early on, rather than waiting until March to see the evaluation, to see how it's coming together and what we're learning. Because I think the sooner we look at it, the sooner we can improve even the evaluation framework, and we can get some really good so what's by the end of the year one effort. So I just wanted to offer that to the committee, and something we can pick up with Liz outside.
Thanks, David.
Thank you, Chair. Looking at the strategy outcomes, it's really good to see one of the bullet points as being reducing health inequalities. But when I was looking at the operating plan, I couldn't see any actions or identified programs of activity in order to achieve that outcome. Is that something to be added at a later date? Are we linking with the national program of Core 20+5, for example, etc.? Thank you.
Thank you. So it is hidden in there, but you'd have to know, I guess. The quality account. So one of our quality account priorities is health inequalities. We're looking at 2 different areas, and it will be through that reporting structure. I guess that's one of the things we need to consider. How can we reflect that back here without drowning you with information? So it's certainly something that will come back up through QPSC as a regular reporting, as quality accounts does. I'm not sure how we would reflect it further here without, as I say, adding even more information.
I think it's a really good question, so thank you for asking it. The way in which we discuss, yes, of course, there's targeted actions that we do, but everything, the way in which we look at data, the way in which we report everything should help us reduce health inequalities. And at the moment, I think there's more work to be done. I don't think we have the answer, and I'll offer a couple of just reflections. We look at average data for everything across a very big geographical patch. We will never be able to tackle health inequalities effectively as a board if we are reporting certain things in that way. We don't cut the data in a way that would help us highlight some of those issues. So I think there's a lot more work to be done, but as Margaret said, it's the balance of seeing the right information without drowning ourselves into it's already quite a hefty pack to go through. So I think we need to take the challenge away and keep bringing it back. It is in our operating plan. We've got 2 areas of priority. It's the mental health and it's frailty that we're looking at in particular this year. But how would we know, and how do we kind of bake it into the way that we look at the data? And again, just the fact we look at a CAT2 mean across 30 days, across a huge geography, we know that we have different, and that's an inequality to start with, and you can start unpeeling that. So I think we need to take it away as a very healthy challenge as a board. Know that we do have a work plan in place, but then answer the question of how would we know, and maybe bring that back and do some reflection on it.
And just to reassure, we are connected to the network, and we provide a self-assessment regularly. The last one we did showed us an organisation. We've got a fair way to go. We're going to be doing that more formally again in about 3 months' time, and at some stage I'd quite like to bring that back probably to a development session.
Excellent. I'm minded now to move us through to, well, first of all, I have to break the bad news, which is we've passed the point at which we're going to have a break. So I'm going to have to say that we'll have to do, if anyone wants a comfort break to get a drink or anything else, then please do that. We won't take a formal break as we have 1 hour left and we still have substantive part of the agenda to be able to go through. I think the other thing to say is thank you all in terms of presenting on this first theme, and also the responses, and Liz in terms of bringing the committee perspective. I think we'll need to reflect further on, I'm sure you will, as an exec, to be able to say what you felt has gone right or wrong in terms of how this has worked as an assurance process. We will also, obviously, as non-execs, we meet, and when we meet, we will sit and go through this to be able to see what else we're able to do. But I think what has come out, going back, I'm going to earth back to Michael's original comment, and it carried through as a theme in terms of patient. And I think recognising the challenge on patient outcome, because even if you're looking at cardiac arrest or stroke, the ambulance service is only a small part of that care pathway and the likely outcome for that patient. But that shouldn't mean that we are not focused on that patient outcome and the element that we can put within it. And I think more broadly, and that will sort of connect back to Howard's half the side of the A4, is that I think what we're saying as non-executive colleagues in particular is to just make sure that patient experience, that patient voice really does come out from all the, as Karen said, enormously strong work that's gone in and the reporting. And I would, absolutely agree with you to be able to see some of this detail, and the strength of it is really, really positive, because it allows us to be able to both have the assurance and challenge where we need to challenge, but to be able to get that orientation. So if that is okay, we're then going to move on to...
I do appreciate timeliness. I tend to be the exec welfare support because we do tend to sit a lot. Personally, if you're right, I would like a 5-minute break just to stretch my legs. I do think it's important we do just take a break for everybody to
do
stand
that,
up
absolutely.
for 5
Let's do that. Let's do that. I'm happy to be overridden, and there is actually a thing, isn't it, that we should stand up every hour. We should stand up every hour.
So just 5.
But you've reduced it down from 10 to 5.
Yes, Chair.
We will be back at 10 past exactly and going again. Thank you all very much, and thank you in particular to Emma for there we go. We've done that with good integrity all round. Fantastic. Excellent, excellent. Right, let us press on then. And we're on. That seemed to work in terms of, thank you very much, colleagues, that seemed to work in terms of just a little bit of adjustments, and we could continue on with that. So we're going to have Andrea covering for Sarah, who's going to talk about our people enjoy working at CCAM, and then Max covering for Subu will respond in terms of the people committee report. So over to you.
Lovely, thank you. I'm really conscious of time, so I'm going to try and triangulate all of the documents together and be as speedy as I can. So, yeah, so our ambitions around our people enjoy working at CCAM. And obviously, you know, HR, we've had a huge focus on us. And what we've worked really hard to do is try and narrow down the areas that we're going to focus on because there is so much to do. So our key areas are around employee relations, culture and retention, and our operating model. So if I start with ER, we had a diagnostics, which I think you've already seen sight of, and we had a deep dive following that. And as a result of that, we've been able to secure funding to be able to bring in some extra resource to help us around training, to help us around casework as well. And that's currently out to tender at the moment. So we'll be able to really have a solid focus on employee relations to try and get us to a point where we're actually then able to handle new cases more appropriately. We have also we're also looking very much at our, sorry, I've lost my train of thought, sorry.
Oh, take your time.
Sorry, I was all organised. We've also made within the team some small adjustments just to make sure that we have some kind of small scale adjustments just to make sure that we've got the right people reporting into the right roles and to make sure that we are really sure in our casework. We have a risk in the register around staff culture and morale, which is around working with our unions. And that is one of the things that we are really working hard at. So we have regular meetings every week with the unions. We have suspension meetings with them weekly. And actually the aspiration is that we start to work even more collectively with them and start to do things around joint training, etc. And we've actually got a meeting with them on the 22nd to talk about our joint our terms of reference that we can start to do to work together. We are also looking very much at an informal resolution, and that will kind of, at the moment we very much go straight to grievance and straight down the formal route, and that can obviously lead to some tensions. And what we're really going to try to focus on is informal resolution. So we've had 2 cohorts of mediators that have been trained, and the last group finished their training last week, and that will be supported by a resolution policy so that we can try to move to a culture of getting people to have those conversations before actually things go formal. And that should really then start to help to build those relationships and actually have less reliance on the trade unions having to be tied up in lots of grievance investigations. In terms of culture and retention, lots of things happening there. We've actually got a retention group and we actually have a culture group. So the culture group meets every 2 weeks. And what it does is hold us to account for the actions that we're trying to put together and make sure that we report back on. Retention, as we know, is a big issue, and I know there was a retention plan that was put in place previously, which we are now refreshing, and we've got some targeted work that's happening now to triangulate all of our data so that when we look at our retention plan going forward, it's kind of from an evidence base. So we're looking at things like, for example, ex-interviews, where we know at the moment we only have about a 9% response rate, and we've got people that are actually, we've got someone in the team who's actually taken that on as a big project, as well as looking at other elements around retention. So at the session in September, we'll be able to share a lot more of the work that's happening around that. We've actually got someone that's working with us actually from David's team to, because there are so many actions, to make sure that we keep on track, so that we can give assurance to the board that everything that we are saying that we're doing, we are doing, and where there's going to be any gaps in that, that we'll be able to report to you why. In terms of our operating model, we are actively looking at carrying out some changes within the HR team, which is going to be very much supporting us to align and be able to work with the strategy, and also to make sure that we've got enough resource that the programmes that we do particularly if you think around leadership, which is going to be a huge area of focus for us, that we've got the right people in place to be able to deliver those programmes. And so that's a key focus for us generally. Just very briefly touching on the IQR report, we know that sickness is not where it needs to be, but it is coming down, and we've actually got a real focus on long-term sickness. So we know, for example, that when people go off, we're not necessarily great at keeping track of them, and therefore being able to get them back into the workplace a lot quicker. And grievances, they're in high numbers, but as I referenced earlier, we have got some funding coming in, and actually we are slowly starting to resolve them a little bit quicker. Appraisals, I know, was flagged and we touched on, and we've got a cross-organisational working group that's going to be looking at ways that we can improve that, alongside looking at, I've been looking at with Stephen, a learning management system so that people can record appraisals easier, and as well as touching on earlier, the focus on those quality conversations. So I think that's it from me. Any questions?
That's
I've tried to rattle through too
quickly
and I lost track of myself.
Absolutely fantastic, Andrew. Thank you so much. You did that very, very well, because that, being able to talk around the system changes and the system improvements, but also focusing on some of the metrics that we're seeing really allows us to sort of balance between the two. And then if I hand over to Max to be able to talk it through that channel of the committee, and then I can open it up for questions.
Yeah, great. Thanks very much, Chair. So People Committee papers and discussions centre around seeking assurance on those key topics relating to the Our People Enjoy Working at CCAM priority. Our last meeting was on the 9th of July. If we look back to the foundations laid last year, we were pleased to formally close the People and Culture Housekeeping Project, with thanks to everyone involved, but also to see what's next in terms of those ambitions and priorities from a culture perspective, and plans to track and report via a culture dashboard. More work to be done on that. Then looking forward to our 24-25 BAF, specifically the HR Improvement Plan and ER casework outcomes. And we had a really constructive discussion on the outputs of that diagnostic and deep dive that you just mentioned. And the key ask of the committee was for a really realistic delivery plan that would both provide the assurance and track delivery and manage expectations and ensure accountability. Worth saying on the point of accountability that something that really shone through that meeting was actually the clear exec alignment and shared responsibility for making what are key improvements to the people agenda. That responsibility doesn't sit solely with HR, and that was a burden and a responsibility that was very visibly shared by the exec. There's also a really important discussion around appraisals and the appraisal target of 85% plus. Pleased to note as a committee the significant progress year on year that's been made, but it remains still below targets. Committee was, however, assured that the right focus continues to be placed on this area, and the barriers that are preventing us hitting that target, and Andrea's just mentioned the sort of the technology and systems discussions. But there's recognition that this is a really important dimension of enabling our continued culture change journey and broader ambitions, and the committee looked forward to seeing continued improvements. And then we finished the meeting on the 9th of July with more of a point of interest, a rich discussion around professional standards and actually what could the future model look like for that. What are the opportunities to think beyond regulatory compliance alone, and how could we incorporate the scope of clinical and non-clinical? Committee recognised our Chief Paramedic Officer will own that. She's not here yet, but we very much look forward to seeing further thinking and the evolution in this area. Bit of a potted summary of the report, but happy to take any questions in Suba's absence. Thanks very much.
Thank you so much, Max. And I think, again, that gives that oversight. Thank you. Very clear in terms of what's been happening at committee level, and then that connects in terms to Andrea. So we've got basically, again, to be able to reflect on the board assurance framework, the integrated quality report, and any particular questions in terms of how the committee has been operating. Margaret.
I just wanted to add 2 points to Andreas, which is just to bring to the board's recollection and attention. I've got the privilege of sitting on all the committees, and in a couple of the subcommittees lately, so audit committee was the last one we talked about the retention plan. So it's just to come back to that. The board will recall we signed off a retention plan at the end of last year. The refresh that's been done is that various aspects of life have changed a lot between then and now, and there's areas of the retention plan that are no longer reflective of where we'd want to be as an organisation and allow the strategy and the values, but also reflective of the financial situation. But in a positive way, we recognise investing in training, for example, is probably more important than someone having their birthday off. So when we talk about the refresh, it really is in light of that kind of thing. So it's just to assure the chair, yourself, the chair, and the NEDs, that is some of the background behind that. And then secondly, regarding the investment to bring in support for the cases, there has been criticisms or comments that investment has gone in quite a lot over the years into HR. So I think it's just important to note that the number of cases that are being dealt with and the complexity, and of course the longer they take, the more complex they become, and the more you get engrossed in other areas such as legal matters, that we're never going to tackle the downstream if we don't get some support to deal with what's happening. In the background to that, as more resources put in to deal with those complex cases and the volume, the sheer volume, the team are going to be able to, and are already providing training for our current leaders and managers to be able to manage cases so that we can get to them quicker and we get there with the right responses. So just wanted to add some support to the work that's going on in HR that as executives we all support and back up.
Very helpfully said, Margaret. Thank you so much. I'm going to turn to Howard, please. Sorry, Howard, can I just ask you if you can just, in terms of the mic pickup, if you're facing forward, we pick up everything. If you move your head to one side, we get about 50%. It's gone quiet. Any other further comments, thoughts, reflections? There you go. What stunned silence? Just it was. You thought that, Andrew, but then Karen's going to come in.
And to echo some of the comments that were made, clearly a huge amount of work has gone into this, and rightly so, but I know these kind of improvements don't come easily. One of the themes that runs throughout is about the relationship with the trade unions. And I wondered if you could illuminate a little bit more about that and how you see that working going forward, particularly in the context of the important point that you've made about pay disputes potentially this year and how that may impact on some of our other ambitions.
I think what we're really trying to do is engage with the unions as much as is possible. So, for example, the ECSW, which David mentioned in the Chief Exec report, and that is in there, we work really closely with them at every stage through. So the whole thing we're trying to do is make sure that they are not on the back foot, that they're with us every step of the way. And I think having the weekly meetings with them on a Monday has really, really helped relations. And I think that's starting to build that trust that we will actually tell them what's happening in advance, even if there's a communication that's to go out. So, for example, I was in a meeting with the unions yesterday because we've got a communication going out about ECSW, but we just wanted to check the wording with them. So those sorts of things are helping them to feel a lot more included, which means that when we come to kind of the harder stuff, as it were, we've got those relationships already built up. Yeah.
Excellent. Well, we've got this as a topic next month, development-wise, so that there'll be the deep dive there where we will have further time for work. So that is fantastic. Thank you very much, Andrew, in terms of that cover. That allows us to move on to Sustainable Partner. Simon, you're going to be kicking us off, and then we're going to hear from Howard from Finance Committee.
Thanks. So I'll cover off the BAF, then take us through the finance report, then hand over to Stephen, I think, who's going to cover digital. Matt, who'll describe some of our partnership work, and then Howard can bring in the finance committee report. So the summary in BAF for Sustainable Partner, we have now concluded our planning for 24-25 and have submitted a plan which is control total compliant. It's a deficit of £10.5 million. We are forecasting that we will deliver that plan this year, including the cost improvement plans embedded within it. We've undertaken, as an executive team, a review of our internal controls, have implemented some of those and continue to work to improve the way the organisation is run. The 3-year recovery plan, we expect to be able to deliver our first draft of that to Executive Committee by the end of this month. Digital strategy work is ongoing, but nearing completion for sharing with Exec Committee and then the Board in due course. And we continue, as ever, to work with our partners in progressing our strategy. Key amongst that work is the hubs, which Matt will describe, but also looking further forward, the extent to which the ICBs are able to support the 3-year recovery plan that the Trust has and the 3-year strategy implementation that we have in the context that we find ourselves, where we'll likely have a 1-year settlement for next year, before we get into a comprehensive spending review position. So that's a broad summary of where we are. In terms of financial report, you'll see that we continue for month 3 to report a deficit position forecast full year of £16.5 million. That reflects our formally submitted plan. However, since that formally submitted plan, we have identified further income that we think we can achieve, and therefore felt confident in going further in achieving the £10.5 million deficit that I described. Just for technical reasons of timeliness and submission, the difference between those two, £6 million, is reported within the ICB for month 3. So they're reporting a positive £6 million variance in their position, which, if you add those two together, comes back to a £10.5 million position. We expect that to be corrected formally for month 4, so that will clear that up going forwards from month 4. So, year-to-date, broadly in line at month 3. We're doing month 4 as we speak. Yeah, the forecast in line with plan as well. Capital and cash slightly ahead of plan. Those two are related, but we expect to deliver both our cash and capital plans by the end of the year. So that's probably all I'll say on the report. The report's there. I'll take it as read. At that point, I'll probably hand over to Stephen, who'll talk us through the digital position and strategy.
Thank you, Simon. So, colleagues, where we are in terms of the digital strategy, the clinically led, digitally enabled strategy is now at the point where we will start the formal review cycles to make sure that the comments that we've heard on the way, predominantly from our clinical colleagues, is really resonating and aligned to our strategy. The document has been drafted against the corporate strategy. So that's where it's really being taken to. And what the corporate strategy is asking for is how we're going to enable this organisation to work going forward. Multiple reviews have been had with external partnering, and Paul is holding me to account as the non-exec director for digital. A couple of other things I would like to add. The cyber review is something that's really important to me. Personally, there's an external cyber review that's happening across all ambulance services, which us in CCAM are the owner for NHS England. So we're starting to see what that looks like. How do we compare to our peer group? What that also will mean in terms of any resilient activities that we need to continue with. I would hope by the time we get to October, at the October board, I should be able to share what the national review has said about us as CCAM. So for me, the other key element of the strategy is the enablement. Now we've had, over the last few weeks, we've seen some challenges around our network and how that's supporting our support services and our staff. So there's a key piece of work to look at the network itself. We need to have foundations which we can grow from. I think the final one, which is the clinical leadership around our electronic patient and care record and how we support access to clinical data. That's the other key element of the strategy that I'm working through, which completely aligns with the corporate strategy about making sure that we put our patients and our citizens at the centre of what we are trying to achieve. So to give assurance to the committee, I'm at the point where we'll be starting iterative reviews going through August, September, hopefully to take that to a point where I have permission through FIC to bring it into this committee into this public board for sign-off in October. I'm happy to take any questions, but really that's an update on where I am currently.
And then just before we move on to Howard and then questions, Matt, give us some updates on our work with partners.
Thank you, Simon. I think we've had a good discussion already around the unscheduled care navigation hubs and what we're looking to achieve through those and how they will support the delivery of the strategy. The area within the BAF that I'd just like to point colleagues' attention to is around productivity and collaboration. And it's just to provide an update post the regional review into ambulance services within the South East that was undertaken by Carna Farrer. So those recommendations have been presented to NHS England, and as a result, a governance framework has been established, which feeds into a South East regional ambulance transformation steering group. And that's coordinated by the host ICBs for the respective ambulance trusts and NHS England. We had a really encouraging and beneficial design workshop with SCAS a couple of weeks back, where we took the recommendations from the regional review to look at what is feasible within this financial year. We looked at collaboration opportunities and agreed on design and implementation principles that we would like to take forward with SCAS as the ambulance service that we're looking to collaborate with. I think it would be fair to say, as has been highlighted as an escalation to the Board of Directors within this area, that there are fairly minimal cost-saving opportunities in year for this financial year. However, encouragingly, we have absolutely identified some opportunities to be working alongside and with SCAS colleagues and our wider ambulance service community within the South through the Southern Ambulance Service collaboration moving forward. Just to give an example of areas that we are currently considering to potentially explore, we know there are opportunities to work together around procurement. We know there are also some opportunities to look at how we can work collaboratively around education and training. An area that's been highlighted and been observed by both NHS England and the South Central Ambulance Service as an area for learning is the work we've done into quality improvement. So our QI framework and the robust education and training specification that we have that works alongside that. So we're currently in discussions with NHS England because clearly this requires additional capacity if we want to accelerate these work streams at pace. And we're also working in conjunction with our ICBs and NHS England to look at what do we perhaps need to work and progress on with South Central Ambulance Service as a collaborative across our border versus what do we now need to look at transferring into the broader Southern Ambulance Service collaboration. So we'll be bringing back a further update at the next board meeting. And as I say, we've covered the other areas, so I'll probably stop there on that update. Thank you.
Thanks, Matt. And I'm going to bring Paul in, Howard in. But just before doing that, just to say for all colleagues, this is probably the one element that doesn't fully align in terms of the Finance Committee. Some elements of what's considered within this theme operate in other committees. So what I would ask is that we do focus probably thematically on questions and lead out with finance. And with that in mind, I'm going to move over to Howard. Sorry, my light went out for some reason. And you've moved somewhere. You obviously need a special place to be able to report back on Finance Committee. You have a Finance Committee room somewhere in your house.
Thank you very much. As is normal, my power just at the critical moment. So I have to go and move to get some power back up. Thank you for that. So, dealing with the sort of finance points of view, obviously, as Simon mentioned, on target for the first quarter. So we looked at the Q1 results at our meeting on the 1st of August. So that's results up to the end of June, where we are pretty much on target. We were assured around the fairly detailed level of analysis on the cash releasing efficiencies of 4.8 million. But we wanted a little bit more assurance on the non-cash releasing efficiencies, totaling some 19 million, so quite a large number. So that's going to come back to committee in September, hopefully with get some more assurance around the delivery of those efficiencies. We sought lots of reassurance, but we just want a bit more assurance on that. The other point I wanted to raise were we were very much encouraged by the level of an extensive work plan on the financial controls and also on the procurement improvement plan. All very, very good stuff, very positive. On the performance aspects of the committee, there were 2 points I wanted to raise. One of the activity level, interestingly, assumed in the plan, you may recall, is 2.3%. And that's a sort of general activity level. I think originally we assumed 4%, but we then stepped it back to 2.3%. I think the board should be aware that the actual year-to-date activity level, something that obviously beyond our control, but an important aspect, is 7.1%. So in the first quarter, compared with our plan of 2.3% activity year on year, it's 7.1%. So if that continues, that represents a fairly major challenge to us. Obviously, but it may not continue, but I thought it was important to just draw that to the board's attention. It's a big increase in activity level, well over and above evening is on target at the 30 minutes. So that's great. Really good news. I know that there were some challenges at the beginning of July that they were temporary. Yeah, really good news on the C2 performance. C3 and C4 presenting some challenges, but very good performance so far. That was it for me.
Very helpful. Thank you, Howard. And I think I might actually initially just kick off with Howard's point in terms of that known unknown variable that does give us all concern in terms of activity, and just be able to sort of push that one back before I sort of open up with further questions, to be able to say, first of all, any comment in terms of that as an activity level, also to try and get an understanding of how that sits nationally. Is this something we're seeing in terms of local variation, or is this something, and any other further comment that wants to be made? Because as I say, we could see ourselves walking into a real challenge if this continues.
Answer that.
Yeah, thank you, Chair. We've had a number of conversations about some of this recent uplift and activity, because it is recent. As much as I can't actively quantify it, conversations I've had with different people have indicated not only that other trusts have had an increase in that period of time, but A&Es are also seeing an uplift in activity of walk-ins during that time. So I think it's fair to say that there was a short period in time of July where everything just ramped up. So we do recognise what Howard has said, that our meeting our performance is very important. That starts with the call answering, because I'm very pleased that we are consistently now delivering call answering performance within the ARP standards, which is a really solid position for us to be in. So we're getting the right quality of support for patients the moment they call us. And our C2, yes, it did have a bit of a challenging period for a couple of weeks, particularly in July with this recent surge. But we are still at just under 28.5 minutes for the year to date. And we are doing a lot of work to make sure that all the right numbers and all the right hours are in the right places. So I think we do acknowledge that activity. As much as we will do all we can to plan and predict, there will always be slight anomalies that come in, but it's important that we understand them and then we can address them. But just to add that if you look at the key efficiency markers, such as job cycle time, wrap-up times, those kinds of things, they're all in a strong position for us. The C and conveyance rate is still on a downward trend. We do also recognise, and actually David and I had a conversation with our colleagues in the NHSE regional team yesterday about this, that one of the other questions for us is, and we've talked about system partners, our hospital handover time is actually still above where it needs to be. So we need to factor that into some of the conversations as well. But I hope that answers a bit more of the question about the activity and the performance.
Yeah, helpful, and I think we'll have to keep a sharp eye on it. I think that's the other part of it. It's not necessarily we can do anything with it, and I think it is a level of assurance, Emma, that you say that you're seeing this for other in other areas, because it means it'll come up on national radar, and therefore we won't necessarily get the finger pointed at us alone. That's very helpful. Can I also just step in? I don't know, between Howard and Simon, just one of the things, just noting, it was very helpful, and again, assurance to be able to say Q1 performance in line with plan. But I did notice that, you know, the Morecambe and Wise, all the right notes, but not necessarily in the right order, that there was a lot of variations within that to allow us to land on that sort of controlled total, and whether there's any comment that you have, any discussion within the committee that you had, Howard, or any comment that Simon would want to make in terms of any of those areas of variation that were cause for concern. There we go. Just as that goes on hold, Simon, do you want to provide any other sort of further comment while we wait to see if Howard can reconnect?
Or be controlled.
We got that end. Your signal's dropping off a little bit, but we did actually then get the final part of what you were saying. So thank you very much, Howard. And
Okay, thanks.
Simon, anything to add?
No, thanks.
Any other questions in relation to finance in particular? And then, as I say, we've also got digital and then Matt in terms of partnerships. Over to you, Karen.
Just a quickie, I know you're going to pick up on the activity stuff, so we don't need to go into the detail, but a plea, as well as looking at finance and performance, can we also look at the implications of that on staff safety and patient safety in terms of how we're carrying that? Thank you.
Michael.
I know we talked about it, Simon, at the Finance Committee, but given the the strategic challenges that the public sector as a whole and the UK as a whole faces in terms of its public finances, we do know that there is a one-year review by the Chancellor and then a spending review. So can you just explain, I think because we are in public session, the recovery work that you're doing, is it to get us to resolve the deficit? It's what, because I think that would be worthwhile to give a bit more certainty about what that will entail, because there will come a position that as the wider initiated by the Treasury, the spending review begins to take impact. The Department of Health will be asked to look at its spending plans over the next 2 years to 3 years, and it will trickle down through NHS England to us. I appreciate it's very early days, but do we have any indication of the timeline and how we are preparing ourselves for that? And I presume it is the recovery plan.
It is the recovery plan. We've agreed with commissioners that recovery plan will be a 3-year process. That's the target we've set ourselves, but that's clearly going to be negotiated with NHS England throughout. So, no, it's not known. But our estimate of our own capability to achieve it is 3 years. The shape of that recovery is relevant also, and materially impacted by the settlement that NHS England receives next year. So very, very difficult to navigate with precision, given the national funding position in the NHS and the wider public sector. Hence, asking for our local ICBs to think about how they can commit to supporting our plan in that context. So it's not just ours to solve.
I understand. Yeah. No, I just think it's good, Chair, that we know that this is something we're going to have to return to over the next. And just building on that, the next theme is about partnerships. So I think it's really good the work that we're doing with SCAS. I'm not surprised it's procurement, and throughout my career I've seen joint collaboratives before and everybody picks on procurement as the first one. No, that's not a criticism. What I would say though is, and it relates to the funding position, I would say, and I recognise fully that nothing can be done probably in this financial year, but as far as we can influence this, I think there needs to be some precision going forward. Some of the collaboration where it might lead financial benefits will need a lead time. And I actually think planning this now and being understand what that lead time is, when we're likely to get any financial benefits, is really, really important. And you mentioned about the governance, and I just would hope the governance is focusing on some of those issues because they are really, really, really important. Not a criticism, I recognise early days, but I think it's something that we need to be banging the drum on that one.
Yeah, just to respond, I think I agree with all the points. The report is formally being presented to chief execs in August, later this month, and we are drafting, in behalf of the two trusts, a response to NHS England, which will come to the two boards separately. And clearly the two boards remain and retain sovereignty on the decisions that the organisations make, and we've been very clear about that in the governance setups that are being set up at the moment.
Okay, and my only comeback would be to say this is, I think they need to be ambitious if we are to have credibility with NHS England more widely. I recognise the sovereignty of individual boards, but sovereignty means also about really working in a joint way to deliver benefit.
Yeah, being close to this work, this is about aligning 6 ICBs, 2 providers in the region on a single plan. So bear with us, we'll bring back the plan in October.
Good to set that ambition though, Michael, thank you. Karen.
Just briefly on the collaborative work, 3 areas, procurement, education, training, QI. I was surprised research wasn't mentioned, research and innovation, and maybe that's more of an enabler, but within the context of the discussions we've had today, I think it would be really helpful to think about that when we're looking at some of these other issues. Thank you.
I think we have an opportunity. Clearly the report was done independently, and it was commissioned independently to review the opportunities. I think there's a lot of opportunity in research and innovation in how we bring some of the models of care to life. So the good news is that a lot of the work was blueprinted on our strategy. So the language of the models of care is being used as the blueprint by which we may look at doing this consistently. So one of the challenges is, well, what may a core offer of UEC look like across the 6 ICBs across the southeast, to which we can mirror and dock a standardized ambulance model, because at the moment Skies and Seacom have 2 different operating models. So a lot about this is achieving, removing unwarranted variation and consistency in the way that the trusts operate. That in turn will give us quite a lot of, funding and procurement opportunities, for instance, because a big issue that we have at the moment is how can we remove variation if we're trying to meet the patient needs in 2 slightly different ways. So I think there's an opportunity to bring that in through the way in which we talk about how will the models of care be implemented across the southeast. So thanks for that coming out. We'll take it back into the group.
Excellent. If there's nothing further, then again, thank you in terms of presentations, and thank you also, Simon, as I say, that went very quickly in terms of being able to say getting that financial sign-off sort of as running and moving at the same time. I think it's no small achievement to be where we are. We recognise there's sort of still the challenges in terms of being able to deliver for the full year, but we were in with a very good chance because of good work, in addition to the system work that's being done. Equally, I'll just say, Stephen, on digital, again, thank you for your work on that, because I think that's giving us a head start because of what you're doing. We know there are going to be funds available for digital. We know that there are going to be partnership opportunities available around digital, and you're giving us a very good opportunity to make the best benefits of that as well. If that's okay, we've got 6 odd minutes, a couple of items, and actually we're going to go back, I think, to Matt to talk on Sussex ICB delivery plan.
Thank you, Chair. So I'm presenting this on behalf of the Sussex ICB. So as highlighted in the cover sheet within the documentation, the board has been formally asked to endorse the Year 2 refresh of the Sussex Integrated Care Board Shared Delivery Plan. This is their joint forward plan. It's their strategy that's refreshed each year as per the ICB constitution. The document that is linked within the cover paper provides a summary of achievements by the system in year 1, and it sets out the priorities for health and care partners to focus on for this financial year. As a reminder, the board formally endorsed the fuller shared delivery plan for the Sussex ICB last year, so this is a refresh and provides the updates for year 2. I'll just take just a minute just to hopefully highlight just some of the areas of alignment and then provide the recommendation to board colleagues. So if we consider the alignment of the system shared delivery plan with our strategy, it aligns with our aim to deliver high quality patient care. There is a clear focus on improving response times within 999 calls, and also reducing A&E wait times. There's also initiatives that focus on growing and developing the ICS workforce, of which we are included within that, ensuring that staff are better trained and supported, which complements our second strategic aim to best support our people. The key focus of expanding out-of-hospital care looks to reduce the burden on acute hospitals and UEC services and focuses on developing pathways to provide care within the community. Encouragingly, the shared delivery plan really looks at how UEC and community services can better integrate to provide seamless care transitions and improve patient outcomes. And one of the ways they're exploring that is to accelerate and introduce these integrated community teams. These teams would align with our unscheduled care navigation hubs, so it's timely for us. And within the shared delivery plan, it's clearly articulated that this approach would also look to manage high-risk patients and optimise pathway utilisation across both urgent emergency care and community services. We are involved in the development of the accompanying urgent emergency care strategy for the system. And I think the last point I would make regarding the shared delivery plan is there is clearly an emphasis on digital transformation, and it mentions improving triage, dispatch and introducing virtual care services, which clearly supports our innovative and revised approach to caring for our patients. So in summary and in conclusion, we have contributed to the shared delivery plan update via our strategic partnership managers and our clinical and operational leads within the Sussex system. And I'd like to recommend to the board that we look to endorse the year 2 refresh of the shared delivery plan, as it supports our strategic aims and enhances the overall health and care delivery within one of our 4 integrated care systems. Thank you.
Very, very eloquently put, Matt. I'm going to see if there's anyone has any questions. As I say, I think that's really, really helpful in terms of information. Just as a sort of a further point of information, I would probably reckon that around 50% of my time working with partners is working with Sussex at the moment. And I think that is a little bit of a reflection of what they're doing, but also the fact that they're very much reaching out. They see us as being a system partner, not just a sort of, I'm not saying that any of the other systems are doing that, but they're very much front foot in terms of their engagement with us. So I think that's another positive reflection. So thank you for that, Matt. Then we just have the recovery support program. Going to give us a quick update.
Thank you, and this is something that we will continue to bring back at every board. We had 11 of our enforcement undertakings as part of being in SOF 4 closed. We received a letter last month as part of the review that we did, which is great news and testament to some of the improvement journey work that we've been doing over the last 2 years since the last CQC report and being put into the new form of special measures. The focus now is on 3 key areas, as you will see with the remainders that are open. Those are the only ones that we will be bringing back, which is clearly linked to some of our strategic aims for the year. So financial sustainability, as evidenced through the development of a multi-year plan that has been signed off by the ICBs, is one of the key things that we're focused on and part of our plan for the year. Improvements in our culture and HR effectiveness as part of the plan that Andrea has presented to us is the second area of focus. And the third one is around overall what I'd call leadership sustainability, which is reflected through the fact that we are going through a change at both the board and at an executive level with new posts and a new model that we want to implement. So those are the 3 big areas alongside the things that go hand in hand, such as governance and sustainability of that governance, to ensure that we continue to be connected, from road to board to what's happening with patients and what our people are telling us and how we drive the improvements. But I think the board should note that 11 of the enforcement undertakings have been closed, and congratulate and thank all the colleagues in the trust that have worked really hard to help get to that point. Thank you.
Thanks, David. And I'd reinforce that most fully. I'd also just say, Peter helpfully reminded me, we just need to also, with the ICB plan, just officially confirm our endorsement. So there we go, and Paul again has been able to, there we go, lots of thumbs up and nods to be able to do that. So that's Excellent. Right. So with 1 minute to spare, board effectiveness, when it says, are we compassionate, curious and collaborative? I'm going to just be able to say I'm very, very keen to be able to get feedback. We're not going to get that in 30 seconds when we're all really quite hungry and tired. So we need that breath. But please do, get back to me, get back to Peter, make sure that we're getting good feedback on what has worked, what hasn't worked, what we can be able to tweak, because this is an iterative process, and I'd view that in terms of also governor feedback and wider public feedback. If there is nothing further, then I don't think we have any matters of any other business other than I can immediately reference back to values now, because Emma's tested me on the values to be able to say, don't say anything, or if you do, say very little. And I'm going to sort of do the integrity bit to say I've heard you, but I'm not going to fully follow through on that. To be able to say, really, we do all want to, as a board, thank you so much for all the fantastic work that you've done. Really, and in terms of as I came in and walked in the door, it was really evident in terms of what you've done, in terms of grabbing hold of operations and really helping us put that framework to do everything that we're talking about doing. So we know that you're not just running out the door. You're relocating back up to the northwest, and we wish you all the very, very best. And we do hope, as I say, we keep in touch, because we'll want to be able to see what you're doing, what we're doing. So we hope to be able to say a huge thank you for everything that you've done. I'm afraid there is, it's not a blankety blank checkbook and pen. Just you'd probably actually prefer that, but it is to be able to, be able to hand this over officially, and to do it. Huge thank you for everything you've done. There we go. I do then open to be able to see if there are any questions from any members, any governance members of the public, and I'm looking online to see if any hands go up. And I've got Martin, I think. Thank you so much, Martin. I'm going to hand it. There you go. Emma was thinking that my last comment was that was it, but yeah, there you go. Never say never.
Never
Back to
say
you.
never. Thank you. So I think we need to go back a little bit, a step back a little bit, Martin. I can see you on the big screen. We need to help, continue to help on both a regional and a national level, our population, public, people that we live alongside every day, use the right service at the right time. 111 has grown enormously from when it was set up about 15 years ago. And their capability of dealing with the non-emergency presentations is absolutely excellent. And if you look at the volume of calls that go through 111, they will do the same on a Saturday that 999 does in the whole week. So fundamentally, when you're asking about how these two things interact and how we get them working well, because I think I heard your question about which one, you know, how do I know which one to call? Would you call one or t'other? The reality is, if people have got lower acuity calls, we need to, or presentations, we need to keep working with them to understand that 111 is the point of contact. 111, I'll go back to something I said earlier on in the board, has the ability, for example, to direct book into general practice, has the ability to direct book into emergency departments. That's what it's set up for. That is what it's commissioned for. And as much as 999 is exploring avenues into that, what we need to do is be very clear, and part of the strategy is absolutely landing this. An ambulance service needs to get to the critically unwell more quickly, more effectively, and get them to definitive care more efficiently. And that's what our strategy is going to be all about. It's why we've got, you know, it's all over the strategy. 111 is always also going to be a challenge because it's commissioned very differently, which means inherently there are tens of providers across the country who, whilst we all work in a similar way, are very much commissioned by the ICBs that they work for to deliver in a slightly different function. So I suppose what I'm saying to you is we are learning from our integration between our own 111 and 999 services and the positive impact on patients and systems, and working with Surrey to say how can we make sure that the same benefits are being realised with their 111 provider and are working with them. The hubs, I think, are an addition on top of that, working alongside the systems to manage 999 calls. But there will always be, as we develop, some learning about how to access pathways across. You know, we have clinicians who will work on working with urgent care in EOC who also work in 111. We've done so much integration now. We're bringing that learning between the two. So I think we're in a strong position for that. So I hope that kind of answers that position.
Thanks so much, Emma. And I think if you're comfortable with that, Martin, I'll just see if there are any other. Oh, we've got Matt. Did you want to add to it? And then I have one.
Yeah, I think it was just to answer Martin's second question, just to provide some reassurance around the virtual response or virtual consultation approach. So absolutely, as has been highlighted, there are a range of options when we look at virtual response, virtual consultation. They could include a telephone call, they could include video consultation. We are extremely fortunate that we have been joined by Stephen as our CDIO colleague that's come from East of England. And East of England have done some of this already very well around integrating the CAS and looking at how we can best virtually respond. I don't think we have the answer as yet, but what we've absolutely set out in our service model is, in an emergency, if a patient requires a physical response, they will absolutely get a physical response. And likewise, if we believe that it would be appropriate to virtually respond to a patient, but actually we can't do that effectively, we have built in measures and means whereby we will still send a physical response to assess that patient, even if that patient is considered lower immediacy or acuity. So just to offer that reassurance, Martin, to your question.
Thanks very much, Matt. And I think it was a very important point made, Martin, in terms of when you said both in terms of age or anything in terms of language. And I think, as Matt's explained, we're sort of factoring that in. We'll have to see as it rolls out, but it's certainly been considered and it's certainly been factored in. We have a question in the room.
I just wanted to give some bit of feedback and talk about feedback as a public governor for West Sussex as it happens. I think that there was discussion a lot about how we get feedback and things like that. A lot of what I saw was what I would say is excellent, but it's formal. It's using a survey or something like that. In my experience, the most effective feedback is as immediate as possible. It's informal, and in some ways it's unexpected. And one of the things that people sitting around this table, who have executive roles particularly, can do is just to encourage that to actually happen. I've mentioned this in a previous, I think it was probably a board meeting. I worked in a very large company. We merged a number of units. The director who was responsible for that looked every day, and it required feedback up as to somebody who'd gone out of their way to deliver every day. And that person would have a voice message from the director personally in the morning. Now that kind of instant feedback is what really turns the screw in terms of getting people's morale up. We are appreciated, we are noticed. I was tremendously pleased to hear Howard's comment about how we talk to the public. It's got to be about, what are you going to notice different? Because yes, strategy means nothing, and there's too many. And most of the words are whiffle words. It's what changes. And yeah, we need to celebrate success. And in that vein, I'd just like to say, I went out for a 12-hour shift, third manning on an ambulance in the last week or so. And it was superb. The two guys I was with, Alex and James, were out of Brighton. We had to deal with a death. We also had to deal with, they were so switched in that they knew that there was a category 1 patient about 6 minutes from us, but we had a category 3 patient in the truck. So they diverted so that they could get there within 7 minutes, because our patient was totally stable. And I was there, I could hold a radio. If anything had happened, they could have been there in seconds. But it meant that we got there within the 7 minutes. The second truck, which was on the way, took about 4 or 5 minutes longer. Whether that's made a real difference in the outcome, I don't know. But by God, it was the right decision. That, all the time, throughout that day, they were living the values. So, Emma, you've got a good team there.
What a lovely way to be able to, thank you so much, what a lovely way to be able to sort of draw the board meeting to an end, because that really, I think what you're throwing down the gauntlet in terms of being able to capture, I think, both at staff and patient level in that sort of, in the moment, and I think we can reflect on that, because I think there's very much something in that, and then again, just to be able to reflect what you're hearing on the ground in terms of how we are already sort of living our values, but also showing the flexibility, using the values to be able to show the flexibility. I think, thank you very much for doing that. Thank you all then for the comments and questions on following the meeting over just a piece of over 3 hours. Very much appreciated. We now have a short break and then we will return for part 2 of the meeting. Thank you all very much.